Hello everyone, and welcome to our 11th edition of the Advanced Cardiac Imaging course. Obviously, these are very strange times, and as you know, for those of you that have attended previously, we've always had this meeting as a face-to-face meeting, but this year we'll obviously have to try something different. And we're going for a virtual hybrid format. So there will be some live sessions in and around the panel discussion and some of the interpretation of the talks, but you'll find all the talks are pre-recorded. I'd like to say a big thank you to Millbrook for helping us organize this and getting the logistics in place. Obviously, these are very challenging and difficult times, and hopefully we can have a nice, slick 4 to 5 hours worth of state-of-the-art presentations, which I hope you'll all enjoy and will give you a lot of educational content. I'd like to say a big thank you to the speakers too. There's been obviously a lot of pressure of time to get all the pre-records in, but everyone got there just on time, and so we are all ready to go. A few housekeeping things I just wanted to alert you to. You can see that on our housekeeping slide, we have the opportunity for you to ask questions. So please do use the box on the right-hand side of your live stream if you would like to submit questions. Try and do it in a timely manner in the session, because we obviously will have to review the questions and just select some of them if they aren't being covered. And as you can see if you could use Twitter to put the word out. We'll be very interested to hear about your thoughts on the format and the use of this sort of virtual pre-record type session compared to live sessions, because obviously we need to plan for the future, and your feedback would be gratefully received. And at the end of this is all obviously being recorded. You will get a chance to have a look at it again. Finally, I would just like to say a big thank you to our sponsors. So as you know, we provide this session essentially free of charge. There's no registration fee. And a big thank you to Abbott, Terumo Boston and Edwards for yet again providing the excellent and most valuable support for this course. So sit back, enjoy. I've got great pleasure in introducing the first session chair, Dr. AJ Jain, who's going to take you through angiography and physiology.
Thanks, Anthony. And on behalf of my fellow panel members, Ollie, Guttman, Dan Jones, Elliot Smith and Andreas Baumbach, I'd like to welcome you to this session, which is on angiography and physiology. We've got about 55 minutes to go through this. There are three really excellent pre-recorded talks, which we're going to start very shortly. But to start off with, Steve Hamshere, one of our senior registrars, is going to discuss a difficult angiogram, and that case will then be debriefed by Dan Jones before we start the pre-recorded talk. So to hand over to Steve now, please present your difficult angiogram.
Hi, I'm Steve Hamshere. I'm one of the cardiology registrars at Barts Heart Centre. I've been asked to give a talk on a difficult angiogram. Firstly, I have no conflicts of interest to declare. So this case is a 42-year-old male who recently had an anterior STEMI with successful PCI to his LAD. He returned 6 weeks post-STEMI for an elective admission for physiological assessment of a moderate diseased right coronary artery. He had good LV function, and his bloods were normal and had good response to statin therapy to his cholesterol. However, he was at ongoing angina class CCS2 and was on good medical therapy, bisoprolol and some ISMN. So, from his left coronary disease, you can see he's got some mild disease and a high bifurcating OM1. And the results of the LAD was very good, with distal flow to a large LAD. On his right coronary artery, he had a long segment of at least moderate disease in the proximal vessel to mid and some distal diffuse disease. It was decided to perform an IFR on this patient. And as you can see from these readings, they were all negative at 0.96, 0.96, and 0.97. However, due to his ongoing angina, it was felt that an FFR should be performed. And as you can see from these readings, they were both positive at 0.75 and 0.73. And when pullback was performed, you had 0.77 in the mid to distal vessel, up to 1 at the proximal vessel. So after this, it was decided to stent the right coronary artery with predilatation from the mid to the proximal vessel and stenting from mid to proximal, then overlapping proximal vessel. FFR was performed at the end of the case, and at 2 readings, they were both negative at 0.94 and 0.95. As you can see from the final angiographic results, So very good results in the right coronary artery with some diffuse disease distally. And again, in the RAO, a nice angiographic result. So there is still much debate about the best medical management of bystander disease post-STEMI, especially regarding angiographic guided versus physiology. The best invasive physiological assessment is still unclear. This case highlights the disparity between hyperemic and non-hyperemic assessments. Also, if the physiology doesn't make sense, consider other methods. Thank you very much.
Thanks, Steve. That's a great case to start the meeting, and one which highlights a really important issue relevant to everyday practice. Namely, with so many different physiological indices currently available, which is the best to use and when? Or more precisely, are there circumstances when we shouldn't be using certain indices? In Steve's nicely presented example, two validated techniques, that's IFR and FFR, both with equal guideline-based recommendations, give different answers, which clearly can lead to confusion about revascularization decisions. So what do? I think this sets us up nicely for this session on cath lab-based physiological tools to help guide our treatment decisions. And I'll hand back to AJ to get the session started.
Thanks, Dan. So we've looked at a case where physiology was incredibly helpful in making decisions about the revascularization strategy. And I'd now like to go to our first talk. V Kunadian is going to talk on ischemia with normal coronary arteries, and he's going to ask us if angiography is no longer enough in terms of assessing those patients. So if we could go to Dr. Kunadian's talk now, please.
Thank you very much, Andreas, for this kind invitation to give this talk entitled Ischemia with Non-Obstructive Coronary Arteries, Angiography is No Longer Enough. My name is V Kunadian. I'm an academic interventional cardiologist based at Newcastle University and Freeman Hospital, Newcastle upon Tyne. I do not have any financial conflicts relating to this presentation. However, I had the privilege to chair this EAPCI expert consensus document on INOCA in collaboration with the ESC Working Group on Coronary Pathophysiology and Microcirculation, which was endorsed by the Covadis group. So INOCA, the problem. We know that angina pectoris affects several million people, to be specific, approximately 112 million people globally. So it is a major health problem. And of course, when patients have angina, the common procedure that's performed is coronary angiography. And it's very interesting to note that when we do angiography in the setting of angina and evidence of myocardial ischemia, up to 70% of patients do not have obstruction on the coronary arteries. As interventional cardiologists, we are probably used to we are used to seeing stenosis in the coronary arteries, and we fix them with a stent like I have shown there. But of course, coronary microvasculature does not stop at the level of epicardial arteries alone. There is a huge network of microcirculation that will contribute to patients' symptoms and the findings on the various perfusion imaging. And it's also important to note that INOCA happens, the frequency is more common in women when compared to men. So this slide shows on the right-hand side is the condition of ischemia with obstructive coronary arteries, and they follow the normal pathway depending upon whether it's a chronic coronary syndrome or acute coronary syndrome. And the one that is often missed or undertreated is this ischemia with non-obstructive coronary arteries. And the endotypes, as we have shown here, are the coronary microcirculatory, microvascular dysfunction, and vasospastic angina. And often these patients do not have obstructive coronary disease on imaging. And these mechanism, which is coronary microvascular dysfunction as well as vasospastic angina, can occur in both conditions, in those with and without obstructive coronary disease. And patients with INOCA can present with a wide spectrum of signs and symptoms, which is one of the reasons why patients might often be misdiagnosed and leading to under-investigation and under-treatment. But many patients often present with symptoms similar to angina. It's important to note that their patients might also present with other characteristics such as breathlessness, indigestion symptoms. It's also important to recognize that there is a gender variation in the clinical manifestation of both obstructive and non-obstructive coronary artery disease. The consequences, if INOCA is not correctly diagnosed, it can lead to misdiagnosis, and as a result, no tailored therapy is prescribed for these patients. If they are not treated with the right therapy, then of course they're going to have a recurrent angina with impaired quality of life, and that can lead to repeat hospitalization, repeat coronary angiography, and sometimes it rests with the clinician themselves because of the non-characteristic presentation of these patients and the fact that there's no obvious stenosis on angiogram could lead to paradoxical reassurance by clinicians and even refuting the symptoms that the patients present with. And you might say, so what? The reason being, INOCA is not a benign condition. It is indeed associated with adverse short and long-term prognosis. Patients who have INOCA have reduced quality of life, increased disability that leads to recurrent hospital admissions, repeat angios, and all of these in a setting such as the one that we have in the UK with the National Health Service. The cost has huge implications on our healthcare. And more importantly, INOCA can lead to excess morbidity and mortality, and that's why we really need to take this condition for our patients seriously. And this is a paper pretty much showing that if you have normal coronary arteries and diffuse or angiographically diffuse coronary arteries, doesn't mean that these patients don't come back. Actually, it's associated with excess burden of hospitalization for repeat angiography procedures. And more importantly, INOCA can cause an increase in all-cause mortality and myocardial infarction, the incidence of which increases even further when myocardial ischemia is proven using non-invasive imaging. So it is a condition that we should not take lightly. And all of these is essentially led us to develop this consensus document so that we can provide some guidance to clinicians to investigate these patients beyond the angiogram as such. And obviously, here we're dealing with stable angina patients, so we start off with a non-invasive evaluation, of course, followed by detailed clinical history, which is essential in all areas of patient care. So we suggest CT, coronary CT angiography to elucidate coronary disease, whether it's obstructive or non-obstructive, and to go beyond that to undertake functional imaging using perfusion imaging or cardiac MRI to demonstrate evidence of ischemia. Based on that, we don't stop there. We take things further to come to a definitive diagnosis of the various INOCA endotypes that we describe in our consensus document, to undertake invasive evaluation using a diagnostic guide wire with the use of adenosine and with or without adenosine, and in particular with the use of acetylcholine. And as you know, acetylcholine is suggested in the recent ESC chronic coronary syndrome guidelines. So what it does is that it helps us to diagnose further the evidence of coronary microvascular dysfunction, which we specify as a coronary flow reserve less than 2 or IMR more than or equal to 25. And with the use of acetylcholine, we can demonstrate evidence of epicardial vasospastic angina. So the reason why we do that is that we may not end up stenting these patients because they don't need stenting. It's the microvasculature and the epicardial spasm that we are treating so that these patients receive the appropriate pharmacotherapy. As you can see, the management of microvascular angina and vasospastic angina, the choice of pharmacotherapy is slightly different. But to emphasize in great detail, as we do with every form of coronary disease, the importance of secondary prevention, which includes addressing lifestyle factors and risk factor management, which cannot be emphasized more. So therefore, hope I have convinced everybody that a failure to diagnose coronary epicardial disease in a patient with documented angina and ischemia should not just stop there. It should really promote a subsequent search pathway to elucidate the INOCA endotypes before the patient's symptoms and the findings are dismissed as non-cardiac in origin. INOCA, of course, is associated with wide variation in clinical presentation, and these should not be classified as non-cardiac, particularly given the fact that this condition is more frequent in women when compared to men. And INOCA is not a benign condition. I thank you very much for your attention.
I'm sure you agree, a really excellent summary of our approach to INOCA, and I'm sure we'll have some time in the panel discussion at the end to take some questions from the delegates and from the panel to the panel members. So if you do have questions, please put them into Millbrook via the portal. The next talk, we're going to look at the future of coronary physiology and angiographic derived physiologic indices, and William Wijns is going to present that talk again as a pre-recorded talk, which will be coming onto air right now.
Hi, are you ready for it? Good. What I'd like to do is share with you my view on the great value of image-based computation of FFR. These are my disclosures. Now, when it comes to physiology, we have a problem, and it's a durable one, and it's called low adoption. A couple of years ago, we asked nearly 500 colleagues, would you please look at these angiograms and tell us whether you need anything else to make decision? And colleagues said, well, no, it's okay. In 71% of all cases, our colleagues said, I don't need anything else but the angiogram, no need for physiology. And of course, we had the fractional flow reserve data for each of these stenoses, and the decision was wrong in half of the cases, dramatic. Now, with the emergence of resting indices, no need for adenosine, which was often said to be an obstacle, so Gabotot said, let's repeat the registry. And these are the results that we obtained in 2019. So there is a little bit of an increase in the use of physiology, but still in many, many cases, the angiogram is declared to be sufficient. And in this particular case, the decision was wrong in 39% of the instances. So when we compare ISIS 1 versus ISIS 2, we do see a statistically significant increase in the perceived need for physiology, but still in the vast majority of cases, the decisions are based solely on the angiogram, unfortunately. So the problem is that we think we don't need any other information than the angiogram. And of course, that's very disappointing after having spent decades trying to convince colleagues of the importance of physiology and also having provided the data in support of that statement. So the solution, though, is here. And the solution is based on the computation of FFR from the angiogram. 3D reconstruction, different models. It's called QFR that I've been involved with from the onset. So the physiology is available at the same time by default. You're looking on the angiogram on one screen and the functional test on the other screen. So it's online, contrast-based, no need for pressure wire, no adenosine, and importantly, no medical decision about whether I need it or not. Now, this is the first meta-analysis. It's a patient level that I'm sharing with you here. There have been a couple since then, but this one is patient level. And it shows basically that the diagnostic metrics are amazingly good if you compare the computed versus the measured QFR or FFR in this case. So look at these metrics, and let me tell you the following. You select your preferred non-invasive functional test. None of them, no non-invasive functional test has this level of sensitivity, specificity, and even more importantly, likelihood ratio, because that matters so much in the individual patient. These are the patient level data, so the correlations are pretty good against the pressure wire, measured on the horizontal axis. In fact, some discordancies, but mostly in the lower part of the graphs when the value is abnormal anyhow. Now, we like to argue and discuss about gray zone and, outliers. Please, let's enjoy the fact that we have on one screen, at the tip of a click, the angiogram and at the same time the co-registered QFR in this case. I say QFR, but there's other methods available. Just one word about the University of Sheffield. Colleagues have been working on this topic for years, Prof Lawford, Julian Gunn and others. There is also now ongoing an analysis of the computation of IFR through Philips. Actually, the core lab in Galway is serving to analyze those data. And you can also use, in addition to angiographic images, you can use intracoronary imaging. OCT, for instance, it's called OFR, or IVUS as well, it's called UFR. Now, don't think that this is the future. It is today. Let me tell you about one trial that's actually ongoing. It's called Multi-Talent. It's a randomized study between two stents. The one stent that we're testing here is the Cruise Ultratin Struts. Did very well in the Talent study. Now we're going to bring it to triple vessel disease. Randomization 1-to-1. This trial has all the ingredients of best practice for multivessel PCI, and it starts with risk stratification. So the investigators are sending these data plus the angiogram to the core lab 24/7. We calculate the syntax score number 1. It's 18, so pretty mild severity of the disease, triple vessel, but probably 3 focal lesions, no CTO. All the clinical variables listed here allow you to compute the syntax 2 score, but also the recently updated and actually available for download syntax 2020. Okay, 4-year mortality, the same with PCI and CABG, and on the right-hand side, 5-year MACE, 10-year mortality, pretty similar numbers. So the bottom line is equipoise between CABG and PCI, and therefore it is appropriate to ask this patient to enter the trial, which he did. And so after risk stratification, what happens is randomization, either a stent, and now comes QFR, because QFR is used in this trial to identify which lesions on the 3 vessels are functionally significant in addition to being severe by the angiogram, and those will be treated. In this particular patient, big right coronary artery, upper left, diffuse disease, but very tight lesion proximally. LAD also some diffuse disease, proximal lesion not very much visible in this view, and a very tight lesion in the proximal circ with some distal disease as well. The investigator receives the QFR analysis, color-coded images like here, but also graphical display. If you look, for instance, at the right coronary artery, all the pressure loss happens proximally, meaning that the diffuse distal disease, same color, orange, no further pressure loss at that level, no need to intervene there. So these QFR images are inherently co-registered with the angiographic GPS. And of course, in this particular case, the 3 lesions are significant, so the recommendation was triple vessel disease PCI. And also you can perform the same analysis on the post-PCI control angiograms. You have the results here, very nice dilatation on the proximal right, nothing was done distally, and also QFR calculated on the left, remarkable, 0.96 for the circ, 0.99 for the LAD, meaning that PCI, triple vessel PCI, has restored the normal conductance of the left coronary artery in this patient, so we can anticipate a very good anatomic and functional result. That's it. I hope I've convinced you that the future of physiology is not based on pressure wires. The future of physiology will be dependent on its availability by default from computational techniques.
Excellent. So we've made good progress looking at angiographically derived physiological indices. And I think we'll now go on to a talk from N Curzen, who's going to look at how we can use the angiogram and, more importantly, the pressure wire in this context to help us make the diagnosis. So if I could ask you to start Nick's recorded talk now, that would be great. Thank you.
So thanks very much for the kind invitation to speak at this excellent meeting. I've been asked to talk about angiogram and pressure. These are my potential conflicts of interest. So let's start with a case. This is a gentleman who presented with what was considered to be unstable angina. As you can see, he's got some coronary disease, diffuse disease in two of his vessels and a relatively discrete one in the other. And the question is, what's his optimal management? Now, based on this angiogram, I can honestly say that I don't know, but with the addition of a pressure wire, it's relatively straightforward to decide that, in fact, he doesn't have any ischemic lesions, and he was treated with medical therapy. So, after all the evidence that I'm just about to show you, but even really just after that single case, why do people not use the pressure wire and physiology more? Well, just don't really want to engage it. Some people are probably dinosaurs, and some either don't understand it or don't know the data. So what I would like to do is present to you some items for you to consider in the decision about whether to use physiology. The basis of it is that the diagnostic yield from the good old elective invasive coronary angiogram is actually not very good. And this is now a historical piece of work, but a very important one. We found this series that there was no coronary disease defined as less than 20% stenosis in all vessels, so pretty strict criteria, in nearly 40% of the patients who underwent an invasive angiogram. That is indeed a low diagnostic yield. And as you know, the revised NICE CG95 guidelines for chest pain of recent onset now recommends non-invasive CT coronary angiography. That's pretty well the first-line investigation for most people. So with a low diagnostic yield and CT now becoming the dominant modality for investigation, it becomes increasingly important that we know data like the data from the excellent Scott Hart randomized trial. The 5-year data were reported relatively recently and showed a very significant reduction in clinical event rates out to 5 years by the patients who are randomized to have a CT coronary angiogram up front. And this is probably showing the power of medical therapy. But it does not provide any data about ischemia. So if you are in a position where the patient doesn't settle with medical therapy and you do need to revascularize, you haven't got any good idea about targets. And maybe in the future, that's where modalities like FFRCT will come along to influence us. And you'll probably hear about that a bit later in the meeting. But just in brief, the reason FFRCT is such an attractive modality is if you do have a CT angiogram in someone with some symptoms and it shows some coronary disease, as in this case, they then may end up going for an invasive angiogram which shows some coronary disease just as the CT angiogram did. And then you need to do a pressure wire to decide whether the patient needs revascularization. And of course, you could have done that all non-invasively with FFRCT. And FFRCT, this is the platform observational comparative study. And it's extremely helpful in showing that for patients presenting with stable chest pain who would have had an invasive angiogram, the use of FFRCT up front resulted in over 60% of them not needing an invasive angiogram at all, and a very, very small percentage who ended up having unobstructed coronaries at the invasive angiogram. And this is a really important observation. I was privileged to present the results of the very first randomized trial of FFR-CT as a strategy at TCT. And the headline of that was that there was no cost difference. But importantly, what it showed was that in the usual care arm, there was a very large number of non-invasive tests which were not necessary in the test arm. And if you compared the use of invasive angiography, there were 22% fewer patients who required invasive angiography in the FFR-CT strategy group, and there were 52% less unobstructed coronaries. So this is a powerful effect, and that was without any price in terms of ischemic events or revascularization. So going back to item 1, the secret here is using non-invasive angiography with physiology. You can probably make a diagnosis and avoid the cath lab in a very substantial proportion of your patients, for which they will be extremely grateful. What about the second item? Well, once you're in the lab, the pressure wire or some form of physiology will help you make the correct diagnosis and help you make a bespoke management plan for your patient. And there's a whole series of data which I haven't got time to show you except very much in brief, but the data really represent the building blocks upon which our use of pressure wire are based. Now, we've known for quite a while that the pressure wire is actually a very good way of predicting major adverse cardiovascular events. If you have a lesion which is ischemic in the orange, and if you have a lesion that is not ischemic in the orange, then the event rate's very low. Whereas there's an association, the lower the FFR and therefore the more ischemic, the higher the MACE rate at 2 years. And there was a series of landmark trials but using FFR. The deferred trial, the result of which could be summarized as stenting lesions that are non-ischemic has a worse outcome than optimal medical therapy. So don't stent things that are non-ischemic. FAME, which is probably the most important trial of all, which could be summarized as saying not stenting even tight non-ischemic lesions has a good outcome. So patients randomized to the FFR guided strategy who would have otherwise had multi-vessel stenting had fewer vessels stented, less stent, less radiation, less contrast, and a lower cost. And then there was FAME 2, which could be summarized as saying stenting stable lesions that are ischemic has a better outcome than optimal medical therapy alone. And since then, we've had 2 very high quality randomized trials of IFR versus FFR, showing that IFR is equivalent in terms of being able to guide management safely. Why does the pressure wire have this big effect on our diagnostic ability and our management? Well, the simple answer is that if you look at any of these type of studies, this happens to be the Ripcord study, if you look at the relationship between the degree of angiographic severity and whether the lesion was ischemic below the red line or non-ischemic above, you see that there is this discrepancy in a very decent proportion of patients and vessels. So that there are lesions that are quite tight, that are non-ischemic, and a lot of moderate and even a lot of mild lesions that are ischemic. And this has been shown time and time again. This is the FAME series, this is the famous randomized trial, and this is a huge series from Bernard de Bruyne's group. And they show exactly the same thing over and over again, a mismatch between our assessment of the anatomical stenosis and the presence of ischemia, and it's in about 1 in 3 lesions. That's how it works. What about in real life? This is a patient who had angina, and I thought she was not attractive for a 2-stent bifurcation strategy, partly because her vessels are generally quite small. And so in order to help me with the strategy, I pressure wired the LED and I pressure wired the diagonal, and it told me that the diagonal was not ischemic. And I felt this allowed me to pursue a strategy where I stented right back to, but not including the bifurcation with a stent in the LAD. And indeed, that produced a non-ischemic LAD, and I never had to touch the diagonal. So that's the diagnostic power of the pressure wire. My third item for you to consider is making sure that your PCI has an excellent result, and that will avoid a return trip for the patient to the cath lab or a worse outcome. This is very important. This is the concept that the pressure wire makes a diagnosis after your PCI, not just before. We've known for a very long time that there is an association between the FFR immediately after stenting and the subsequent MACE rate. So here we see an inverse relationship. The lower the FFR after stenting, the higher the MACE rate. And that's a very important observation. But there are much, much better data available now. This is a very important study published last year, the defined PCI study. This took 562 vessels and 500 patients, and they had an IFR pullback before and after stenting. And the results were really quite astonishing. This is each individual lesion before and after stenting, looking at the IFR with the cutoff of 0.9 there. And you will see that after stenting, when the operator thought they had got a very good angiographic result and were ready to finish, they found that about a quarter of the cases, the vessel was still ischemic at that point. That's really quite sobering, and a similar result has recently been presented in target FFR. The optimistic thing about defined PCI is that if you look at the nature of the lesions after the PCI had been performed, and you look at the type of IFR problem, in a very large proportion of the people in which the IFR was still less than 0.9, there was a focal lesion on pullback, which meant it was easy to identify that lesion, treat it, and then render the vessel non-ischemic. And I think that's a really, really important message. Do more post-PCI checking of the result, because that gives you a diagnosis in the form of saying whether you finished your PCI or not. And then you can re-intervene. So why not intervene on the vessel on the pressure wire and then reconnect it at the end? There's some more data also published last year which showed that you don't have to use FFR or IFR. In fact, if you use PDPA, which is very easy because it's obviously a resting gradient, this is also very powerfully predictive of MACE at a medium-term outcome. So you don't even have to do an FFR or an IFR if not. And in fact, there's an algorithm to be had where you PDPA after you've done your PCI, and if it's less than 0.96, then you can try and find out why and optimize the result, which will be good for the patient. And I think not checking the pressure wire result at the end to make a diagnosis of a good result is rather like this guy. Also linked to this in item 3 is using the pressure wire after you've gelled a side branch to see whether you need to do any more work, and that includes left main lesions. And for a long time now, we've known that if you measure the FFR in a side branch that's been nipped by a stent, there is a very poor correlation between how narrow it looks and whether it is physiologically significant. And in fact, in this series, only 18% of gelled side branches were functionally significant, even when they looked quite tightly nipped. And this probably is especially important when you're trying to diagnose whether to treat a gelled circumflex lesion after a left main stent. And in this series of 83 patients who had a gelled circumflex from a left main to LAD stent, only 17% had a low FFR, a significant FFR. And again, the correlation between how tightly narrow the circumflex looked and the physiology was very poor. And yet, having a low FFR compared to a high one really was quite predictive of target lesion failure. So this is a very important observation. Here's another case. This is another LAD diagonal bifurcation lesion. This time the LAD was significant and stent across the LAD lesion, which caused really quite remarkable nipping of the side branch. And in fact, when the FFR was measured in this side branch, it was of course significant, and that therefore sponsored further treatment, this time with a kissing bloom. And this was the angiographic result of the kissing bloom, which I think looks very good. But if you want to leave that patient with a good chance of not coming back with target vessel failure, then you can do a pressure bar. And in fact, it was not really satisfactory. So I went on to perform what I used to call a reverse crush stent with another drug-eluting stent. And this time the FFR in the diagonal is also satisfactory. That reduces very significantly the chance of this patient returning. My fourth item it's making diagnosis in a different way. It's a bit brave enough to see a lesion that you think looks significant angiographically, but because the pressure is negative, deferring any revascularization. Now, this is a combined series from 2 trials looking at FFR and IFR and what happens to deferred lesions. And the answer is they have a very, very low rate of MACE, the patients. So this is a perfectly safe thing to do. It's the same lesson we learned all those years ago from defer. It's still very safe to defer revascularization if the physiology says the lesion is not ischemic. And it's an important lesson. It's a very important part, in my opinion, for the diagnostic role of physiology. And the J Confirm registry, which was published earlier this year, shows there's probably really a dose response, so that if you leave lesions, the higher the FFR, the lower the event rate. And this is very, very reassuring. And importantly, it's equally true for left main lesions. If you defer left main lesions because they are physiologically negative using the pressure or event rate, and this is extremely reassuring, I think. And if you look at all the series that have been published looking at this, in the defer group, the overall survival from events is very, very, very good. Item 5, efficiency of diagnosis and procedure planning. Let's look at the future. Well, if you're going to do an angiogram in the future, you may not have to get a pressure out of the box, because there are a lot of systems now available which will derive physiology from the angiogram that you take without needing to get a pressure out of the box. And therefore, you'll be able to make your diagnosis both in order to plan whether the patient needs revas, if they do need revas, and also to probably model that revas before you perform it. This is a review article that we've just published, which has all this data in it if you're interested. Another aspect of the future is whether it would be possible to justify doing physiology in every vessel every time. And there are 2 randomized trials that have looked at this, Forecast, which has been presented, and there's more data coming out shortly, and Ripcord 2, which will probably be presented at PCR, I hope. And that was a routine assessment of physiology in every vessel compared to angiography alone. So these 2 trials will look at routine assessment and whether that can be justified. So in summary, Mr. Chairman, ladies and gentlemen, it is a bit of a no-brainer to me that we should use physiology for diagnosis both before we do anything, to determine whether to do anything, to determine which vessel to do the thing to, and then to check that we've got a good result rather than walking off. There is a saying that efficiency is intelligent laziness. I ask you whether we can really afford, on behalf of our patients, not to do physiology when we're trying to make a diagnosis. This would be my algorithm for how to assess patients with certainly stable chest pain. Everyone has a CTCA up front. Those who have significant looking coronary disease maybe have an FFRCT. If they've either got no coronary disease and no ischemia, then you reassure them. If they've got coronary disease but no ischemia, then they're on optimal medical therapy. If they've got coronary disease and ischemia, they're also on optimal medical therapy. But if they continue to get angina, then they have an invasive angio. They probably will shortly have angio-derived physiology of every vessel for free. You can then decide whether they need revasc, if so, which vessel. And in the future, you'll be able to model the PCI part of that revasc in the lab before you actually do it. Thank you very much.
Well, it's very strange not to be able to thank those excellent speakers directly, but obviously they're not with us today, and we can send our messages electronically. By my calculation, we've got 8 or 9 minutes for a panel discussion, so I'd like to introduce again Ollie, Dan, Elliot, and Anthony, and if they Andrea, sorry, and if they can unmute and get their cameras on. I'm going to dive straight in. There's lots to talk about, but I think I'd like to address a question on INOCA first of all, and maybe Ollie, if you can give me your views on this with the rest of the panel members chipping as they feel they need to. But there's such good data, as VJ showed us in her talk, and clear guidelines from the European colleges. What are we currently doing at Barts about INOCA? I don't know if we've got an aggressive approach to how we investigate these patients. Why are the tests being done so infrequently? What's your view on that?
Yeah, thanks, AJ. So, I mean, at Barts, as you know, we use FFR, of course, very widely, and sometimes IFR, but not for this indication. I think it comes down to education and awareness, and of course, the resources available. And we also don't use vasoreactivity testing for microvascular disease at Barts at the moment. I think it's fair to say that we as interventional cardiologists, we're a little bit guilty of stopping to think sometimes when if there's nothing we can really treat in terms of a stent. And I think there's a slow change now, and this is why Vijay's talk is so excellent, to raise the awareness and to make sure that we get to know about this recent consensus document, which really talk to us about INOCA, but of course MINOCA is also very important. And I think, as you have seen, INOCA has enormous cost and implications, morbidity and mortality, and it's therefore really crucial for us to have an increased awareness and diagnose and treat them appropriately. So I think at the moment, I think I'm sure there will be increased use, and it comes back to meetings like this to raise awareness and education and make sure everybody knows about it.
So the key issue might be interventional cardiologists not having something to intervene upon. I don't know if the rest of the panel members have got any views on that.
Well, certainly, I think this may well open up a new field. I refer to a later session where we have a non-invasive view on INOCA as well. We'll see about CT and other modalities. And I think, as Ollie said, we wrote that paper because we want to raise awareness. It's out there. It's not just normal coronaries and the chest pain can't be real pain. It is out there. There is ischemia, and we have methods to define them better, and we can help the patients. So important.
Yeah, true. A very real condition with real morbidity associated with it. And I think it's something we need to be taking more seriously, as you say. Dan, I'm going to ask you about William Wijns' talk. I thought the data he presented was really quite compelling, and it's quite a slow adoption of QFR angio-derived indices across the Cath labs. What's the barrier to these being adopted more quickly, do you think, Dan? Are there ways that we could be encouraging those to be used?
Yeah, I mean, I think that's a great point. I mean, some of it will be similar to Ollie's answer to the previous question. But I mean, William does give a sound argument for a more widespread adoption of the technology. And personally, I think that angiography-derived FFR does have the potential to extend the benefits of physiological lesion assessment to far more patients. But there are a lot of different methods out there, and it's confusing. There's FFR, IFR, QFR, RFR, and I think that can lead to A, confusion, but B, stunted adoption. And I think if we can see more stringent validation to prove that the models of the angio-derived indices work, which just means more data in different conditions, maybe bystander disease after STEMI, pre and post, will give more confidence to people to lead to better adoption.
Great, and I agree completely. I think consistency across the indices so we can communicate what we mean by positive and negative tests is very important. I'm conscious of time, and we're lucky to have some questions from the audience now, but I'm going to direct one quick question to Elliot. How are we going to use pressure wire and intravascular imaging and OCT together? Does my cath lab need 14 machines standing in the corner so I can do all the ones Dan's told me and all the ones that you keep telling me how to do in left main stems? And where are they going to be used? Now, Elliot, we've got 2 minutes, so can you try and summarise the answers to that for me very quickly, please?
Yeah, I think that probably the pressure wire is going to tell us when are we indicated, when should we be doing it. And I think the imaging tells us how. But there's a real need now I'm really impressed by Nick's thoughts about always coming back and rechecking the pressure wire to make sure you're non-ischemic. And the view is very much the same in imaging. And so that is going to have a time implication. But I think if you separate out the when and the how, then you can rationalize the obvious resource limitations.
Yeah, I think the dogma for an imaging-guided intervention and perhaps an FFR-guided intervention is not that you do it at the end to check that it's all great, but you start, you understand, you use it during your intervention, and you look at the results to make sure what you've done is probably was the right thing and worth doing. So I think that will apply to IVUS, FFR, and other imaging modalities. Anthony, I think we've got some questions that have come through the feed. I don't know if you want to pop those to the panel now.
Yeah, there are basically two categories of question. The first is an INOCA question, so I guess Ollie might want to field this one. I think it's the practical issues in and around INOCA, and the question is in and around the fact that surely we should just treat stable angina, irrespective of the pathology, with medication in the first instance. Did you want to comment on that? Why is it important that we make a clear diagnosis?
I think on a very basic level, of course, many of the medications we will use will be very similar, but I think it's really important if you really want to target the individual's disease to understand whether we are dealing with a microvascular disease or whether we have got increased vasoreactivity, and then we can tailor the treatment accordingly. And of course, also, if you then want to address the risk factors for that will also be different depending on what kind of INOCA we're talking about. So I think on a basic level, of course, the patients might end up on similar medications, but I think it's really important to really understand what's going on, because that will determine morbidity in the future and the mortality.
Great, okay, thanks for that. And then hello to our American colleagues who are posting questions fast and furious. The first one probably to Andreas, and it's all great hearing this talk about the various FR technologies that are around, but I guess the question is QFR really ready for clinical decision making?
Well, that's a big question that William has tried to address. There are some validation studies there that compare it favorably with FFR. However, there's a gray zone around the 0.8 threshold, and results don't exactly match all the time in individual patients. It is important to know that there are trials coming up. Pioneer 4 is one that is in preparation, where the strategy of QFR guided versus angio guided intervention will be validated, as was FFR. So I think we'll have to wait for these big studies to come along. I personally believe it has a place, and it certainly will have a big role in the diagnostic cath lab.
We've got time for one more quick question, Anthony, I think, and then we should wrap up.
Yeah, okay. I think most of the other stuff is covered, apart from one which maybe Dan wants to take this, given our frequent conversations in the cath lab in and around it. And the question is really about the validity of FFR and IFR in the non-infarct vessels in STEMI. What do we know about this? Can we use it? What are we going to do?
Yeah, I think very much it's still a work in progress. I mean, there's ongoing studies looking at both technologies. We're recruiting to one study at Barts in terms of biomodern, which is looking to validate IFR in non-culprit stenoses in STEMI. There probably is more data with FFR currently, but not really at the time of the acute presentation, more of a stage 6-week interval. So I think it's still an evolving field and question, and hopefully the sort of ongoing studies will answer it. Will give us a more definitive answer than we currently have.
Okay, thank you.
Great. Well, I think that gives us time just to wrap up what I think has been a very interesting and dynamic session. As I said, the speakers can't be thanked directly, but I hope they're logged on and listening, and the feedback's been very positive on the feedback on the Zoom chat. I'll now wrap up and hand over to the next session, which will be chaired by Andreas Baumbach, and it's entitled 3D CT and MRI imaging. So Andreas, if you're happy to take on that session, thank you very much.
I am, thank you. I will be here with Anthony Dan. Didier Loca will join us, Thomas Treibel and Mike Mullen, which also shows that we have a large spectrum covered in the next section, from PET-CT for imaging, guidance for valve intervention, and the role and future of CT coronary angiography in different clinical scenarios. So really interesting and practically relevant session. But as in the first one, we'll start with a case, a thought-provoking case, and we've set the scene really, talking about big data and individual results. The first case is given by Dr. Alex Usher, who is one of our SPRs at Barts, who has an interest in imaging. Alex.
Hello, my name is Dr. Alex Usher. I'm one of the cardiology registrars at Barts Heart Centre, and I'm going to talk to you about a case today, and the case is labelled what to do with this CT coronary angiogram. And the clinical case we're discussing today is a 64-year-old male who was referred via the Rapid Access Chest Pain Clinic to one of our referring hospitals with chest pain and arm pain on exertion. He has background of hypertension and hypercholesterolemia, and he's previously had investigations 8 years ago for similar symptoms as well. At that time, he had a CMR perfusion scan that showed no significant ischemia, and he also had a CT coronary angiogram at that time that showed he had coronary artery disease but without any obstructive lesions. And so this gentleman from our Rapid Access Chest Pain Clinic was referred for a CT coronary angiogram. And that CT coronary angiogram shows us that he has a moderate 50 to 70% lesion in his mid-LAD, and that's shown in better definition here. As we can see, it's a mixed plaque with some calcification, but also some soft plaque overlying it. There's also mild to moderate disease in his osteoproximal circumflex artery, which we can see on the right-hand side here. Again, it's calcific, but also with some soft plaque. His right coronary artery, which I haven't showed you, only shows minor atheroma. At Barts Heart Centre, we have access to FFRCT via the NHS England funding, and so this gentleman was identified as being a good candidate to having his vessels interrogated with FFRCT. And as we can see in these pictures, the mid-LAD lesion is suggested to be ischemic with an FFRCT projection of 0.54, which is suggestive of being significant ischemia. This is a modified spider view in the FFRCT, and that also suggests that there may be a borderline lesion in the left circumflex after the ostial disease. So this gentleman went on to have invasive coronary angiography, and I've shown you two of his left coronary pictures here, which identifies LAD. As you can see, there is that lesion there in the mid-LAD, although these pictures seem to suggest that it's more mild than moderate on the CT images. I'll show you just two images of his circumflex as well. And this again confirms disease at that ostium of the circumflex, but again it would suggest more on the mild side. Because of the FFRCT, invasive FFR was performed on both the LAD and the circumflex, but these lesions did not show the significance that was shown on FFRCT, with 0.83 in the LAD and 0.89 in the circumflex. And this gentleman was still managed medically and no PCI was performed. So the question regarding this case is, why is there such a discrepancy between the two? Is it because there's some calcified plaque? Is it our image quality? Or is it that we're expecting too much from this technology at this stage? It's worth mentioning here that these are the standard error and standard deviation measurements and values that are provided by HeartFlow, the vendor that provides FFRCT. It's worth bearing in mind that there is a certain degree of error within the test, and this may be why we don't see complete equivalence between the measurements. And it is worth bearing in mind that all diagnostic accuracy studies have found that the FFRCT generally underestimates what the FFRCT value will be, making the results more positive. So what can we conclude from this case? Well, FFRCT can be a useful adjunct to CTCA, and it does improve specificity for flow-limiting disease, but we should be cautious about interpreting FFRCT as an equivalent to invasive FFR. Routine reassessment is recommended for all cases where FFRCT is less than 0.8, and certainly from our local audit of our data here, of which we have quite a few cases now of FFRCT being used, we've found that FFRCT less than 0.8. In 1 in 3 cases that we find that FFR invasively is greater than 0.8. I hope this is helpful for discussion today, and it's good to bear in mind how real-world use of this test is actually performed. No conflict of interest, and I hope we can stimulate some discussion. Thank you.
Thanks, Alex. That's a really nice case to highlight where we currently are when it comes to CT-FFR. The case neatly shows an example of a false positive CT-FFR, which had a negative assessment at the time of angiography. Now, this is something that the literature tells us can still happen in up to potentially a third of all positive CT-FFR cases. I think we're now beginning to understand more about these false readings, for example, the importance of scan quality. However, clearly the invasive physiological assessment is currently and is likely to remain the gold standard. During this session, we now hear further about CT technology and advances and other non-invasive indices. And I'll hand back to Andreas to get the second session started.
Thanks, Dan. So keep that thought. We will come back to this discussion. Now, complete change of tack first. When was the last time you sent a patient for a nuclear study? Here, some of us really prefer perfusion MRI or have just come into a habit of ordering that as the preferred method of choice. Now, just recently, we were asked by one of our colleagues in nuclear to consider that there is actually something new and very modern that should be considered as an alternative. So we asked him to give this talk. Nuclear is back. Rubidium PET imaging and coronary artery disease. Our colleague, Dr. L Menezes from the Barts nuclear department. Leon.
Thank you very much. I'm very pleased to be able to tell you here today about the transformation of nuclear cardiology services at Barts, where we've been doing PET perfusion for the past year. So I'd like to talk to you about its role in imaging a coronary artery disease. I have no conflicts of interest to declare. Myocardial perfusion SPECT done with a gamma camera is a tried and tested technique. It's widely available, it's pretty cheap, and it's safe. And its diagnostic performance isn't bad. Great sensitivity, reasonable specificity for the detection of flow-limiting coronary artery disease. And as the oldest kid on the block in terms of cardiac imaging, there's a wealth of prognostic data, such that we know that a normal scan carries a very low future event rate. And it's an independent prognostic indicator of events, and has been NICE approved with the first health technology assessment in 2003, and then in the subsequent clinical guidelines for the investigation of stable chest pain, such that in the latest update, Ischaemia testing is the first-line test for those patients with known coronary artery disease or those patients who have revascularization. So the current landscape of cardiac imaging in the United Kingdom looks very much like this. This is work from Alex Asher, who we just heard, and it shows that of all the imaging tests, myocardial perfusion scintigraphy is actually the most commonly performed test in the UK, with stress echo and cardiac CT vying for second place, and cardiac CT being increasingly more used in the light of the latest update to the NICE guidance in 2016, which you can see on the heat maps of the United Kingdom on the right-hand side. But myocardial perfusion SPECT is not perfect. The radio tracers aren't the best. They have long half-lives, and that means you need to have a delay between one set of imaging of stress and of rest. The detection systems on the gamma cameras is inefficient, which means you have long acquisition times so that you can collect as many radioactive decay events as possible to generate pictures. And that combination means that some scans can take over 2 days to acquire, which in an era of I want it now, if not I want it yesterday, is untenable. Moreover, there is a radiation dose attached to these injections of radio tracers and the scans themselves. And if you're just using gamma camera SPECT, possibly without attenuation correction, or maybe not as robust in a SPECT-CT machine, there will be more and more artifacts, and this is getting more important in an increasingly obese population, which means that you will have false positive scans or non-diagnostic scans. PET can solve these problems. There are many advantages to PET, and specifically PET perfusion. I think these are the main ones. First of all, it shortens the patient journey dramatically, from 2 days to just 20 minutes. Of all the imaging modalities, it offers the greatest diagnostic accuracy, and with PET comes more imaging data and therefore more diagnostic and prognostic points. PET scanners are inherently PET-CT machines, which therefore means you have built-in CT for attenuation correction to reduce those artifacts, but can use the CT scanner to perform calcium scores or even CT coronary angiography in the same sitting on the same machine. And fantastically, the radiation exposure is reduced to 2.7 millisieverts, something like a 5-fold decrease, and that amounts to 1 year's background radiation in the United Kingdom. The same radiation you get from one birthday to the next comes from this scan. And rubidium is supplied from a generator cart, which means that it's actually available around the clock. You don't have to order the radio tracer in. There's no problems with its decay because it's always there. Rubidium is not new. First of all, what is it? Well, it's an analog of potassium. It's in group 1 of the periodic table, and therefore it gets taken up by the cell membrane across the sodium-potassium transporter pump. The first preclinical experiments were done in the 1950s, and in the late 80s, the FDA in the United States approved rubidium for commercial use. It took a little longer in the UK, and it was only in the 2000s that the first UK experience was actually started. What's involved? The patient comes for an appointment. They have to go through the scanner where a CT scan for attenuation correction and planning is taken, and then they are hooked up to the generator, which I said sits by the head end of the scanner. An infusion of the rubidium tracer is delivered from that generator into the patient, and there's 5 minutes of imaging. Once that's done, you can then stress the patient, commonly with adenosine, and at peak hyperemia, the generator will re-inject another dose of rubidium, and the stress images are required. And that's it. After that, the test is done, and the patient can go. In and out in 20 minutes. So it's not new, and therefore that means we actually do have a wealth of experiential data about these techniques. This is 3 pooled meta-analyses showed that the sensitivity and specificity on a patient basis is in the 90s. And in comparison to other modalities, SPECT, cardiac MRI, PET is the winner with the greatest area under the curve. On a patient level, we have similar data. This is a recent study called the Pacific study, where 200 patients underwent cardiac CT, MPS with SPECT, MPS with PET, and against gold standard of invasive FFR measurements. And it was PET that had the highest diagnostic accuracy for detecting that hemodynamically significant coronary artery disease. PET was the winner in this head-to-head comparison. So it can do the diagnosis, and it can do the same prognostication that we've seen with MPS SPECT. This is from a multi-center registry, 7,000 patients. And again, there's a dose-response effect, effectively, where the extent and severity of ischemia and scar provide powerful and incremental risk estimates for cardiac death and indeed all-cause death over and beyond traditional risk factor assessment. So you can tell the patient how they're going to do, as well as necessarily what's wrong with them with the test. And again, we can use the imaging to guide treatment strategy. This is from a recent cohort, 16,000 patients, and the balance between the benefits and risks of revascularization versus optical medical therapy in this cohort, that balance turned out at an ischemic burden of 5%, which is a lower threshold than we know very well from the Hatchamovich data of, in truth, 12.5%. So again, by estimating the ischemic burden, you can therefore possibly dictate your treatment strategy for a patient. But PET also gives us new forms of data, and the principal one here is the ability to actually perform myocardial blood flow quantification. You're imaging the tracer as it's delivered. This first pass imaging means that you can generate time activity curves of tracer delivery from the chamber into the myocardium. And by solving some mathematics and working out the extraction of the tracer from the blood into the muscle, you can actually calculate in mils per minute per gram myocardial blood flow to the heart. And this gives us new information. If your myocardial flow reserve is preserved, even if you've got a mildly or even moderately abnormal PET scan, that basically excludes prognostically significant coronary artery disease. And even in the absence of that flow-limiting coronary artery disease, myocardial flow reserve can actually reclassify patients. Half of patients might have thought previously were at intermediate risk. If you plug in myocardial flow, you can actually work out their true risk, reclassify them to either low risk in truth or high risk in a proportion. About 50% of the time that will change. And again, you can use myocardial flow reserve and that quantification of blood flow to predict the benefit from revascularization. 12,000 patients, 3 years follow-up. Those patients with coronary flow reserves less than 1.8 have less mortality when they're revascularized. Whereas those patients with preserved myocardial flow reserve actually do worse if they are revascularized. So again, this is the stop-go kind of parameter for what you should do, medical therapy or revascularization. So I'm going to close with some examples to just show you how powerful rubidium PET can be for your patients. Here's a patient with homogeneous uptake on stress, no change on rest, there's no ischemia and no infarction, good prognostic value. Moreover, there's no coronary calcium burden, they don't have atherosclerosis, so there's powerful double zero effect that's to say that this patient's outlook is fantastic. Whereas this patient, similarly, beautifully homogeneous uptake on stress, no change on rest, there's no ischemia, there's no infarction. The calcium score, however, comes in at just under 3,000. So here, you go from no ischemia to the fact that this patient's got an awful lot of coronary artery disease, and you can properly address their risk factors and the lifestyle measures to improve their risk, but still knowing that they don't have any flow limitation from that disease. Compare that with this patient, where there's a large anterior lateral perfusion defect, which practically resolves completely on the rest images, and the coronary calcium shows you that the most burden of that coronary calcification is in the LAD. With an anteroceptor perfusion defect and that degree of ischemia, you know that you now need to go in and fix that lesion to relieve that ischemia at the very least, and possibly affect their outcome. A similarly large degree of ischemia here, anterolaterally, infralaterally in this patient on stress. Comes back completely at the rest scan, such that there's no infarction, but when we do the coronary flow quantification, the whole heart's myocardial blood supply is jeopardized. The myocardial flow reserve is actually less than unity, 0.71, which is showing there's actually much more extensive coronary artery disease than we're simply seeing on the relative perfusion scan that we have. And lo and behold, at invasive angiography, there's a severe stenosis in the distal left main stem, as well as severe stenosis in the other three epicardial coronary vessels. So this patient is now a surgical candidate. And here again, we have a similar scan, infralateral ischemia. There's the reduction. On the rest images in the middle row, the tracer comes back to normal. But this is a patient with primary vascularization, and we performed cardiac CT and PET fusion in the bottom image. You can see that in this patient who's had previous LAD, OM, and AB circumflex stenting, that the culprit lesions are actually in-stent restenosis in that OM territory, which has caused that ischemia. So now you know exactly, you're forewarned before you go to the cath lab or decide on your treatment strategy exactly what you need to do. So in summary, I've shown you what PET can do, how it can transform the patient journey, reduce radiation exposure, and give us much better and categorical information on how you can make a diagnosis, guide your treatment strategy, and prognosticate your patients. I'd like to thank you for listening, and also thank all my colleagues at Barts and the Heart Centre who have been doing this for the past year. Thank you.
Well, that's certainly interesting and relevant for patient care. I must say, I must probably go back to these slides and get some details out, which I didn't fully get in the first way round. You can do the same, by the way. This is all recorded, and you can come back to this in the coming weeks and look at it again. Now, for something completely different, next up is my friend Niccolò Piazza, who will go through a masterclass, really, of 3D views for heart valve intervention using X-ray and echo.
Hi, my name is Niccolò Piazza. I'm an interventional cardiologist from the McGill University Health Center in Montreal, Quebec, Canada. And in the next few slides, we're going to be speaking about cardiac imaging for transcatheter valve interventions. These are my conflicts of interest. So how the heart appears really is a matter of viewing angle and not of imaging modality. And what we have here on the complete left-hand side is a heart specimen seen in a 3-chamber view, but that same heart specimen can be appreciated by echo, by fluoroscopy, by CT, and by cardiac MRI. Now, we're very familiar with echocardiographic chamber views, and what you see playing just below the title is the 1-chamber, short axis, 2-chamber or bicommissural view, 3-chamber, and 4-chamber views of the heart. Now, these same chamber views can actually be appreciated during fluoroscopy. And what we'll eventually realize is that behind every coronary injection or behind every chamber injection, there lies a chamber view. And so this is a rotational angiogram with a pigtail sitting in the left atrium. As it's going from RAO 90 to LAO 90, if we were to pause at 3 moments during this rotational angiogram, we'd appreciate a 1-chamber or short axis view of the heart, a 2-chamber or bicommissural view of the heart, and a 3-chamber view of the heart. So chamber views do exist on fluoroscopy. This is a CT scan with a 3-chamber view shown in ariocaudal. If we move to LAocaudal, we would appreciate a 1-chamber or short axis view. And if we ride up to LAocranial, we would get a 4-chamber view of the heart. And if we move to a shallow areocranial, we would get a 2-chamber view of the heart. Now, this is the formula, if you will, of chamber views on the fluoroscopic grid then. We have the short axis view in LAocaudal, the 3-chamber view in ariocaudal, the 2-chamber view in areocranial, and the 4-chamber view in LAocranial. Now, if you understand your echocardiographic anatomy, you can apply that anatomy to the fluoroscopic screen, and you'll appreciate where structures lie relative to each other in the various fluoroscopic chamber views. We spoke about the left heart. Now let's talk briefly about the right heart chamber views, as transcatheter interventions on the right side of the heart are becoming more popular. Here we start in an ariocaudal view, as we did for the left heart, but this time it starts with a 2-chamber view of the right heart in ariocaudal. We then move to a 1-chamber or short axis view of the right heart in LAocaudal. Moving up to LAocranial, we get the 4-chamber view. And if you come to a areocranial, you get a 3-chamber view. So the formula for the right side of the heart on fluoroscopy is a 1-chamber or short axis in LAocaudal, a 4-chamber in LAocranial, and these last 2 chamber views are similar for the right and left heart. What changes is the 2-chamber and 3-chamber view of the heart. For the right heart, the 2-chamber view or the RV inflow view is appreciated in ariocaudal, whereas the 3-chamber view, or the RV outflow tract view, is appreciated in areocranial. And so the whole purpose of understanding, or at least communicating with respect to chamber views, is so that we can develop a pattern recognition in structural heart disease when it comes to relating fluoroscopic imaging to CT imaging to echocardiographic imaging. For example, in the 2-chamber view, the aortic valve and mitral valve are always overlapped, as you see in the yellow and turquoise colored valves. On the other hand, if you move to a 3-chamber view, you separate the aortic from mitral valve in the 3-chamber view. In the 4-chamber view, you can get the atrial septum and mitral valve both in plane. And in the short axis view, you can appreciate the relationship of the mitral valve to the green atrial septum. Now, we've spoken about chamber views, and we'll briefly talk about optimal projection curves, or S-curves. The optimal projection curve provides the LAO and RAO views with a corresponding cranial and caudal angulation where a structure is seen in plane. And so there may be multiple views where a structure is seen in plane, but there's only one view where the structure is seen en face. So this is a typical optimal projection curve of the aortic annulus, and as we are riding along the S-curve, we can always appreciate the aortic annulus in plane. The reason why it's important to understand S-curves, or the view where structures are seen en face, is because anytime we are manipulating catheters or prostheses across structures, we should always aim to have them in plane or en face in order to mitigate parallax or foreshortening. This is another optimal projection curve, but this time of the mitral valve. And so as you see, as we ride along the mitral valve S-curve, we are appreciating the mitral valve always in plane. Now, somehow we can bridge S-curves and chamber views as well. Let's take the example of the mitral valve. This is the mitral valve seen en face on CT, and you can see its corresponding view on echocardiography at the bottom right. If we cut from commissure to commissure, we'll appreciate a 2-chamber view. If we cut from anterior to posterior, we can get a 3-chamber view. If we cut from a right trigone to the P1 area, we get a 4-chamber view. In fact, these chamber views are appreciated as you ride along the S-curves. So let's look at the S-curve of this mitral valve, and you can see that in the right lower quadrant, we have a 3-chamber view with the mitral valve in plane. In a slightly areocranial view, we have the 2-chamber view with the mitral valve in plane. In eleocranial, we have the 4-chamber view with the mitral valve in plane. And in eleocaudal, we have the short axis view of the heart, that is having the mitral valve seen en face. We can also have the same ideas for the tricuspid valve. And so here you have in areocaudal the 2-chamber view with the tricuspid valve in plane. You can also have the 3-chamber view with the tricuspid valve in plane, or the 4-chamber view in eleocranial with the tricuspid valve in plane. And again, in the eleocaudal, you have the right heart short axis with the tricuspid valve en face. And so you may find reasons to move your fluoroscopic C-arms in these various chamber views to emulate what you're seeing on the echocardiographic screens, or you may want to fuse the fluoroscopic images to the echocardiographic images in your minds. Now, within the short time span of this presentation, of course, we can't cover it all, but I just wanted to highlight some clinical implications of these chamber views and how they can be used in everyday clinical practice. So the 3-chamber view on fluoroscopy or on CT or on echocardiography is a great view to assess the risk of LVOT obstruction when it comes to transcatheter mitral valve replacement. This is the view where both the aortic and mitral valve are both in plane and should be used to assess this risk. Whenever conducting transcatheter mitral valve replacements through a transeptal approach, I always do it in a 4-chamber view. That's the view where the atrial septum and mitral valve are both in plane, and having them both in plane, again, mitigates or eliminates the parallax or a foreshortening of the path that your delivery catheter is taken, and also provides a very comfortable view where we easily understand the 4-chamber view or the Valentine heart as it stands in the chest. So finally, we've been accustomed to modality-dependent terminology, where the interventional cardiologist suggests that he's working in an ariocaudal view, or the echocardiographer is saying, I'll work in a 3-chamber view or a short axis view of the heart. But really what we need to be moving towards is a modality-independent terminology and the use of chamber views, which can be found across every cardiac imaging modality. As we said, in echocardiography, in CT, in MRI, on fluoroscopy, even MIBIs have chamber views. These chamber views would provide a modality-independent terminology such that the interventional cardiologist might say, here's a 1-chamber view of the heart, and the echocardiographer will also be showing a 1-chamber view or a short axis view of the heart. Thank you very much.
Thanks, Nico. I think that was amazing use of imaging and certainly thought-provoking. We'll hear more of that, I'm sure. I think everybody in structural intervention should once see this talk. It's an eye-opener how to rotate the projection. We'll discuss that later and move on in the program. Now on to CT and the use of CT in a specific patient subset. The next talk will be given by Dan Jones. Dan is a high-volume coronary operator here at Barts. He's also an academic with an interest in trial. So he not only does he propose the use of CT-CA now in patients with previous bypass surgery, he also has a trial running on it. Dan.
Hey, good afternoon. I'm Dan Jones. I'm a lecturer in Queen Mary University of London and at Barts Heart Centre, and I'd like to share with you our experience of using CT coronary angiography for the assessment of coronary artery bypass grafts. Now, we know that bypass surgery remains the commonest adult cardiac procedure performed in the developed world. It's well established that the procedure improves symptoms and prognosis, especially in patients with diabetes and multivessel disease, hence the Class 1A indication in recent ESC guidelines. However, the long-term results of bypass surgery are hampered by the gradual failure of bypass conduits, specifically saphenous veins, and by accompanying progression of native atherosclerotic disease. Now, the commonest conduit used is the saphenous vein, with nearly 85% of 1.6 million surgeries involving venous harvesting back in 2015. And we know that the long-term patency rates of saphenous veins are poor, with an attrition rate of 10 to 40% within the first year, with up to 50% by 5 years and nearly 80% of occluded grafts by around 10 years. Now, this means that patients following bypass surgery often need further evaluation or assessment of their bypass grafts, either for the recurrence of chest pain, because of heart failure, or because of preoperative evaluation. And studies have shown that within 3 years of bypass surgery, nearly 20% of people have required a further invasive coronary angiogram to assess their bypass grafts. Now, coronary angiography in patients post-bypass surgery is fraught with difficulties. Bypass grafts arise in variable locations from the aorta and the subclavian, meaning that procedures tend to be longer, have higher radiation exposures, volume of contrast administered and subsequent kidney injury. Procedures tend to be performed femorally, with poorer patient satisfaction and higher complication rates, both in terms of stroke and also vascular complications. Risks are also higher because of the elderly nature of the population and coexistent chronic kidney disease. And therefore, in 2020, is invasive coronary angiography really the best diagnostic test for graft patency and assessment? CT coronary angiography has emerged as an adjunctive or replacement for invasive coronary angiography. It's a non-invasive test that can be performed with minimal contrast, time, and radiation, and provide excellent spatial resolution for the evaluation of graft disease and patency. Here, a meta-analysis published a few years ago shows excellent sensitivity, specificity, and both negative and positive predictive values, all in excess of 95% for the assessment of bypass grafts. However, this doesn't include assessment of the native vessels. CT sees occluded and stenosed grafts very well, with high rates as previously described in the meta-analysis. Small diameter grafts, including lemurs of less than 2 millimeters, can also be clearly seen and visualized on CT angiography. What's difficult to see is anastomotic disease, disease distal to the anastomosis, and native coronary artery disease because of blooming artifact, typically as a consequence of calcification. And this is likely to reflect why, in appropriateness criteria, currently CTCA is only recommended as may be considered or not recommended in asymptomatic patients following bypass surgery. Now, there's limited observational data to support the use of CT coronary angiography as an adjunct or replacement for invasive coronary angiography. There are two observational series, one of 20 patients and one much larger series that was performed locally here at Barts Heart Centre, where nearly 1,000 patients who undergoing invasive coronary angiography following bypass surgery were split into those that had a CT scan as planned prior to the procedure or just the angiogram alone. And in those that happened to have CT prior to the procedure, the contrast volumes were 40% less. There was a 25% reduction in the time of the procedure and a significant 56% reduction in the radiation used during the case. Now, most importantly, complete diagnostic studies were achieved in all patients who had prior CT scans, with all grafts visualized and assessed. Whereas in patients who just had invasive coronary angiography alone, nearly 25% and 335 grafts were incomplete or not studied. Now, this observational data supports further definitive randomized study to see whether routine CT coronary angiography is beneficial in patients undergoing invasive coronary angiography. And this is what we're performing at Barts Heart Centre. In a single centre randomized trial, patients undergoing planned invasive coronary angiography with previous bypass surgery are randomized to prior CT coronary angiography or not prior to their procedure. The aim is to reduce contrast load and subsequent kidney injury and improve patient satisfaction and procedure duration. The study is planned to enroll nearly 700 patients over 3 years. Now, as this study is ongoing, I'm not going to provide or detail results of the study today. However, I'd like to show a few case examples to show how CT can be used in clinical practice and how I would routinely use it. Now, CT can be used to decide on the need for angiography, both to avoid the need or to guide targeted angiography in those likely to need PCI, as an adjunct to planned angiography, and to help plan PCI in those that need it. Now, here in the first case, a 65-year-old gentleman had a recurrence of angina several years after bypass surgery. A perfusion scan, as depicted in the two images on the left-hand side of the screen, demonstrated inferior ischemia. A CT scan performed as part of the trial demonstrated a patent lemur to the LAD, patent vein graft to the obtuse marginal, and a subtotally occluded right coronary artery with an occluded graft, as visualized in the fused images seen on the left-hand side. Coronary angiography demonstrated and confirmed the presence of a patent lemur and a patent vein graft to the OM with a subtotally occluded right coronary artery, which was successfully treated during that procedure with drug-eluting stents. The CT can also help in patients who presented with NSTEMI. Here, a 70-year-old patient presented with a troponin elevation and chest pain. They were pain-free, so were randomized in the study to a CT scan, which clearly demonstrated a severe stenosis in the proximal portion of the vein graft with a patent lemur and unobstructed right coronary. This stenosis was confirmed with diagnostic angiography with an uncomplicated PCI procedure performed with a minimal amount of contrast and time. CT is useful as an adjunct in patients undergoing angiography. Here, a 56-year-old lady who presented with a recurrence of angina after bypass surgery underwent a stress echo which demonstrated anterior ischemia. A CT scan demonstrated a widely patent vein graft to the PD, the diagonal and the obtuse marginal, with an atretic lemur to the LAD and a native heavily calcified left anterior descending coronary artery. The patient was therefore listed directly for PCI to the LAD based on this diagnostic information, which was performed with adjunctive rotational atherectomy with 2 drug-eluting stents, all at the index procedure in under 200 mils of contrast, which would be unlikely if a graft angiogram needed to be performed at the same time. Finally, it's possible to fuse CT with the coronary angiographic images to help locate the ostium of bypass grafts. Here, again, a patient presenting with an NSTEMI had a CT scan which demonstrated significant disease in the proximal portion of the right coronary graft. This CT image was fused with the angiogram, clearly and easily making cannulation of the vein graft straightforward, and a successful PCI was all performed in under 60 mils in under 30 minutes. Now, it's common for patients post-bypass surgery to require further assessment of their bypass graft anatomy. CT is an emerging tool for bypass graft assessment, both to assess the need for angiography, to improve angiographic parameters at the time of angiography, and to provide procedural planning information in the case of PCI. Randomized study is needed and is ongoing to assess whether routine CT-CA as an adjunctive or replacement to invasive coronary angiography is both clinically and cost-effective. These are my acknowledgements. Thank you.
Thank you very much, Dan. That's very convincing, and we'll wait the outcome. I know the trial has enrolled about 50% of patients, so next year we'll have the outcome probably in print. Now, we stick to CT coronary angiography. It's my great pleasure to introduce Patrick Serruys, who's been at the forefront of coronary intervention for the past decades and has recently taken a liking in CT diagnostic angiography. He will give a tour de force, really, about the basics, but also the cutting edge applications of CT coronary angiography. His title, The Only Test for Diagnosis and Management of Coronary Disease That Is Needed. Patrick Serruys.
CT imaging in the full assessment of coronary artery disease, non-invasive approach to plaque anatomy, ischemia, and risk. I have no conflict of interest to declare. I would like to start by 2 casual slides for the layman. For 1 millisievert radiation dose 10 times less than during a catheterization, you will get the anatomic description of your coronaries, a substitute for cine angiography. You will have an assessment of plaque volume and plaque composition with calcium, fibrous, fibrofatty, low attenuation substitute for IVUS OCT. You will have the coronary physiology with fractional flow reserve and epicardial conductance, a substitute for intracoronary pressure wire recording, and you will have the myocardial perfusion with hyperemic state with adenosine, a substitute for SPECT, PET, CFR measured with velocity wire. Using your smartphone, you will be able to share with the patient improvement in these 4 fields of assessment, and you will be able to support his adherence to drug treatment and lifestyle modification, long life. This is really the new and true stethoscope of the GP, internist, and cardiologist. Stetho means chest in Old Greek, and scope means seeing and not hearing. By the way, René Laennec gave the wrong name to his instrument. The anatomic approach, the substitute for cine angiography. The chest pain pathway today is invasive coronary angiography and ad hoc intervention. In patients with new onset of chest pain with stable angina, if the ECG is non-diagnostic and if the patient has normal troponin, he will enter the world of non-invasive tests with stress ECG, dobutamine echo, adenosine, SPECT, PET. Patient will be waiting for appointment, doctor will be postponing the decision, hesitating to move to coronary angiography, and finally, physician and patient will cross the line of invasiveness with coronary angiography, and then cross a second time the line of invasiveness between diagnosis and treatment. 38% of the patient will undergo ad hoc intervention, and in 62% of patients, according to data of Manesh Patel in the New England Journal of Medicine, 62 will have pristine coronary arteries. In other words, invasive coronary angiography was unnecessary in these cases, and the remaining population has non-obstructive disease, which is worse. These patients cannot be treated by PCI or bypass surgery and have to rely on pharmacological treatment or strong lifestyle modification. What is the future vision? Cardiac CT as one-stop shop that will increase quality and effectiveness of our medicine. And in these one-stop shop, you have angiography, fractional flow ratio, perfusion with hyperemia, plaque anatomy, ejection fraction, wall motion analysis, the Lemon score, syntax score, and calcification mapping. And there is only one line of invasiveness to be crossed for therapy. What about the sensitivity and specificity? These slides show the diagnostic accuracy of CTA in patients with suspected but unknown coronary artery disease. The sensitivity is excellent, ranging between 85 and 99%. The sensitivity is good, ranging between 64 and 92%. These slides show pre-test probabilities of obstructive artery disease in more than 15,000 symptomatic patients according to age, sex, and the nature of symptoms: typical, atypical, non-anginal, and dyspnea. And that's in a pool analysis of contemporary data. And in this series, obstructive coronary artery disease was proven by invasive coronary angiography and FFR. And as you could see, pre-test probability range between 1% and 52%. Now in this slide, the pre-test probabilities for suspect obstructive coronary disease validated by the ESC is compared with the pre-test probabilities found in the Scott Hart study. And on the right-hand side, you can see that when the ESC pre-test probability is more than 15%, only 20.7% of the CTA were found normal, and more than half of the CTA show obstructive coronary artery disease. Conversely, when the probability is less than 5%, only 13.2% have a significant stenosis. Nutti and colleagues have reported the performance of non-invasive tests to rule in and rule out significant coronary stenosis in patients with stable angina. It is a meta-analysis focused on post-TAVI test disease probability. CTA has a sensitivity of 97% and a specificity of 78%, and substantial positive and negative likelihoods ratios. That is nicely competing with the performance of the PET, positron emission tomography. In other words, the best performance in ruling out CAD is obtained with CTA, and the best performance for ruling in coronary artery disease is with PET. CTA substitute for intracoronary pressure recording. The next video is a crash course in physiology derived from a multi-slice CT scan. You see the original multi-slice CT scan, the lumen centerline assessment, removing the plaque based on Hounsfield unit, lumen surface determination, myocardial mass assessment, finite elements, computational fluid dynamic based on Navier-Stokes equation, and to end up with the drop in intracoronary pressure and concomitant reduction of flow, a cross lesion with an FFR of 0.98 in the proximal LAD and an FFR of 0.60 distal to the stenosis in the mid part of the LAD. And the FFR change are color-coded with the worst value in red. In this meta-analysis of FFR-CT versus CTA, we can appreciate the superiority of FFR-CT with respect to CTA at the patient level with an area under the curve, and the vessel level with an area under the curve around 0.90 and 0.91. At TCT 2020, the forecast study was reported. The study did randomize patients presenting at a rapid access chest pain clinic and were randomized between a strategy of direct FFR-CT assessment as the first diagnostic test versus routine assessment involving exercise testing, stress echoes, stress magnetic resonance, nuclear perfusion, calcium score, and even surprisingly enough, CTA and ICE. Nevertheless, the result of this approach is a reduction of 22% in invasive coronary angiography. In terms of catheterization laboratory efficiency expressed as the ratio of justified revascularization following invasive coronary angiography versus total number of performed invasive coronary angiography, the forecast confirm other studies such as Platform and Promise, in which a strategy of CTA with FFR-CT renders 112% of invasive coronary angiography unnecessary when compared to either a battery of non-invasive tests of direct catheterization. In the forecast study, a strategy of CTA plus FFR reduced by 36% the rate of unnecessary invasive coronary angiography when compared to CTA. For the National Institute for Health and Care Excellence in UK, the first line test is CTA with FFR-CT that may lead to a cost saving of £214 per patient, with potentially an increase of CTA by 400% and a reduction of invasive angiography by 60%. There was immediately a debate in the European Society of Cardiology, should NICE guideline be universally accepted? And final conclusion was in favor of CTA, provided FFR-CT and high-risk plaque are properly evaluated. Finally, in the European Society Cardiology guideline, of 2019, coronary CTA with non-invasive functional imaging became a class 1 level B. The question is whether CT with myocardial perfusion assessment during hyperemia induced by adenosine is a better alternative to FFR CT. Danish colleagues randomized 600 patients to CTA or CTA with adenosine perfusion and came to the conclusion that CT perfusion reduced the need for invasive examination by 50%. However, the procedure is complex: 2-scan, adenosine infusion, and an increase in radiation about 7 millisievert. The anatomical and functional computed tomography for diagnosing hemodynamically significant coronary disease has been reported in JACC cardiovascular imaging in 6,400 vessels. And the specificity of CTA 0.61 remained moderate for the detection of hemodynamically significant stenosis, while the specificity of functional CT imaging tests and their combined use with CTA is high to excellent, 0.88, 0.80. At some point, we became convinced and confident about the capacity of CTA in helping a heart team in decision-making between surgery and PCI in multivessel disease, and that's the syntax tree revolution. In this trial, we randomized for the first time the doctors and not the patients, and the trial was virtual. Let me explain. In patients with left main disease and 3-vessel disease on conventional cine angiography, a CTA was performed and a single patient was randomized between 2 heart teams. One heart team has only access to cine angiography, and the other heart team has only access to computed tomography and angiography. Then each heart team has to make a decision on the treatment based on the syntax score 2 described in the Lancet 2013 as a combination of anatomic syntax score and comorbidities. And the primary endpoint was the concordance between the 2 decision making by each heart team and was evaluated by kappa statistic. The Cohen test has a value of 0.82, an almost perfect concordance in the kappa statistical jargon, with an agreement between the 2 heart team of 92.8%. And the secondary endpoint integrate the FFRCT in the decision making. You may wonder what is the additional value of the FFRCT in decision making. In our central illustration in Circulation Cardiovascular Interventional Journal, it illustrate the impact of FFRCT in heart team decision making. FFRCT changed the treatment recommendation between PCI and CABG in 7% of patients. FFRCT changed the vessel to be revascularized in 12% of patients, and FFRCT reduced by 13% the number of patients with hemodynamically significant 3-vessel coronary artery disease. Subsequently, we made a pilot survey of the surgeon involving in the syntax tree revolution trial on the feasibility of planning and executing coronary artery bypass grafting based only on coronary computed tomography, angiography, and CT-derived fractional flow reserve. And as you could see, the average agreement on feasibility between surgeons was 84%. The real things has started, and 6 patients have been already operating with the sole multi-slice CT scan guidance. The protocol of the fast-track CABG enrolled patient already referred to CABG by conventional heart team using invasive angiography. After analysis by our core lab in Galway, providing functional anatomy to the surgeon may or may not decide to plan and execute the surgery without viewing the conventional cine angiography. That's the feasibility phase, and feasibility assessment 30 days after surgery. The patency of the bypass graft was assessed by multi-slice CT scan, and that's the safety assessment. The next 4 slides will give a glimpse into the type of visual material that we provide to the surgeon. Mixtures of 3D maximal intensity projection called 3D MIP, and then each vessel is analyzed with multi-planar projection. Here is the RCA with analysis of cross-section and quantified diameter of the vessel in millimeter, so that surgeon can decide on an appropriate landing zone for their bypass graft. Here is the left main and proximal LED in multi-planar projection with detailed analysis of the trifurcation. Finally, we provide the surgeon with the functionality of each lesion in FFR-CT. Lesion with FFR-CT below 0.8 have to be bypassed. In the first case of the study, the CTA planning and operating team use a Lima on the mid-LAD and a saphenous vein graft on the posterior descending. The actual treatment was even better with the use of a Lima on LAD and Rima on PD. Here we see the 30 days safety assessment on volume rendering and MIP with both graft patent. Now, if the fast-track trial proved the feasibility and safety of non-invasive imaging guidance for CABG, then the surgeon in the future may, can, and will operate safely the most complex patient of the CAD pyramid with the sole guidance of CTA and FFR-CT. And then the interventional cardiology should not have any reluctance in intervening on patient whose he knows in advance the anatomy, the functionality, and the tissue composition of the stenotic lesion even before entering the catheterization laboratory, now upgrade into an interventional suite. Finally, CTA as a substitute for IVUS OCT. The video show a virtual pullback through a right coronary artery imaged by multi-slice CT scan. And they are IVUS-like images. Animation allow me to introduce the next topic, which is the non-invasive detection of coronary inflammation that could be detected by perivascular fat attenuation index when the difference in ounce-filled unit between perivascular fat and non-perivascular fat are above minus 70 unit, for instance minus 30, then the perivascular fat is considered as inflamed. When non-inflamed perivascular fat has a negative difference below 70 unit, for instance minus 190, then as demonstrated in a validation cohort of more than 2,000 patients in Cleveland, the impact of inflamed perifat on cardiac mortality is substantial. Now, software for tissue characterization by CTA are becoming every day more sophisticated. This is one of them, showing the lumen field with contrast medium. We see the opacity of a nodule of calcium that will persist after the clearance of the contrast medium in the lumen, a region of strong attenuation with less than 30 ounce field unit in red on the slide is probably a lipid-rich area. And two other regions with intermediate ounce field unit between 30 and 150 are possibly more fibrotic. The next slide shows the change in atheroma volume, plaque, and composition over a period of 5 years in one of our patients. A total atheroma volume increased from 140 cubic millimeter to 159 in 5 years. In panel B, a calcified plaque appears over time. In panel D, a nodule of calcium appears, the lumen decreases, the fibrotic plaque becomes more fibrofatty with area of low attenuation in red. By the way, this year in the European Heart Journal Imaging, Daniele Andreini reported an excellent correlation for plaque volume quantification between CTA and IVUS using 256 slice CT. A few years ago in GACC, it was reported that high-risk plaque detected on CT angiography predict acute coronary syndrome independent of significant stenosis in ACS. The classical high-risk plaque with stenosis of more than 50% are defined as having remodeling above 1.1, presence of area of low ounce field unit below 30, with the classical napkin ring sign and with spotty calcium, all sign of high-risk plaque. Thus, in patients presenting to the emergency department with acute chest pain, but negative initial ECG and negative troponin, presence of high-risk plaque on CTA increase the likelihood of ACS. With the group of Daniele Andreini, we have also demonstrated the long-term prognostic effect of what we call the coronary atherosclerotic burden and validate the so-called computed tomographic Lemon score. The Lemon score takes into account the localization of the plaque proximal of distal in the coronary circulation as depicted by the black cartoon, and the type of plaque, calcified plaque, non-calcified plaque, mixed plaque, as well as the degree of stenosis more or less than 50% play a role in the prognosis. The key observation was that the patient with a Lemon score greater than 5, but with non-obstructive stenosis, has the same event-free survival of 76% as the patient with obstructive stenosis. In other words, at that time, it becomes evident that non-obstructive NOCA is a major troublemaker. Even in the absence of stenosis of 50%, NOCA is a major troublemaker at the median long-term follow-up of 98 months. Even in the absence of diameter stenosis of 50%, positive remodeling, low attenuation plaque burden, and napkin ring sign were significantly associated with higher rate of heart cardiac events such as cardiac death, STEMI, non-STEMI, and urgent hospitalization. More recently, we have seen that the introduction of non-invasive hemodynamic assessment enhanced the prediction ability for ACS risk in the MITRAL trial. Beside the classical adverse plaque characteristic abbreviated as APC in the curve of cumulative risk for culprit lesion on ACS, and these APC characteristics are, of course, positive remodeling, low attenuation plaque, spotty calcification, and napkin ring sign. We have also adverse hemodynamic characteristic abbreviated as AHC, and they are low FFRCT, high delta FFRCT, high wall stress, and high plaque stress. And clearly the combination of these adverse plaque characteristic and adverse hemodynamic characteristic result in the worst outcome. One of the trials in preparation is the INOCA trial in glycerin for non-obstructive coronary artery disease in primary prevention. We are talking at that stage about 1,000 patients, statin naive, in the context of primary prevention with LDL superior to 70 milligram, with a Lemon score more than 5, and with without flow limiting stenosis with FFRCT below 0.8. Patient will be randomized in a double-blind treatment between either statin plus placebo injection, statin plus inclisiran injection, and placebo plus inclisiran injection. CTA will be performed at baseline 18 months and 36 months. If multi-slide CT scan is able to objectivate a plaque regression in non-obstructive coronary artery disease with FFRCT above 0.8, thanks to the administration of microRNA antisense for inhibition of PCSK9, then if it works in primary prevention, then certainly the same type of aggressive pharmacological treatment should be used for the secondary prevention. And conversely, if multi-slide CT scan is able to guide the surgeon in the planning and in the execution of surgery in the most complex case, then the multi-slide CT scan strategy of guidance is applicable to all cases of percutaneous revascularization and invasive and conventional angiography will progressively but inevitably disappear. In conclusion, non-invasive coronary image by multi-slide CT scan with functional assessment by FFRCT could become a cost-effective first line of diagnosis. The adjudication of physiological epicardial conductance and myocardial resistance further boost the diagnostic capacity of the technique. Decision-making between pharmacological treatment, PCI, and CABG based solely on non-invasive imaging becomes reality. Non-obstructive CAD can be diagnosed by non-invasive imaging and become a privileged target for primary prevention based on lifestyle modification with or without aggressive pharmacological treatment. Thank you very much for your attention. Here are my two close collaborators in shadow, Yoshi Onuma, Professor Onuma, and Professor Soliman. Thank you very much.
Excellent. As I said, a tour de force on CT coronary angiography. At this stage now, I'd like to invite my panel for a brief round of questions and answers. Would you all come on? Anthony, Dan, Didier, Thomas, and Mike. I'll introduce you with a question each, trying to do questions that are relevant for our practice. Let me start with the most difficult one, I think. Didier Loca, University of Lausanne and the Swiss Institute of Technology, visiting Barts. A question on INOCA. We've just heard from Patrick that there are CT trials now dealing with that difficult patient group. And in the morning, we heard Vijay, or earlier we heard Vijay, looking at pathways for intravascular increased diagnosis to specify those patients. A, what are you doing? And B, if we had to establish a pathway for these patients, would it be non-invasive or invasive? What do you think? Where's your money?
Okay, thank you, Andreas. So I think it's a very difficult question. So as we heard during all the talk, and we listened that the prognosis, of course, of this patient is far from benign in terms of MACE. And basically the potential risk of the invasive assessment should be weighted against the benefit of the diagnosis for the patient. And we know that common non-invasive technique currently assessing Ischaemia rely basically on detection of large regional differences in left ventricular perfusion in epicardial territories. And currently we don't have a non-invasive technique allowing direct anatomical visualization of the microcirculation in vivo. And I think for that, I think, of course, we are dreaming to go as we can. We all are aware that the recommendation is to go, first of all, non-invasive, but we don't have currently the technique. So I think it's very promising what we see today in terms of CT and even with the rubidium. But if we really want to have a full assessment of INOCA, I think we require currently, I think, invasive tool because of the acetylcholine who can only be administered during invasive testing. But I think it's very promising to see this CT trial and what we currently can develop with the image and AJ.
Okay. New field for interventionists.
Yes.
Mike, question for Mike Mullen, who is our structural lead and doing all the complex structural interventions. You've seen the presentation from Nico. He makes a big case of making the most of the available information by doing the right projections and his S-curve. Last year we were talking about fusion technology. Where do you sit? You do most of your procedures with X-ray and echo. Do we need more? Do we need fusion? Do we need increased imaging? Or are we just happy using what we have in a clever way? You're on mute, Mike.
Beg your pardon. Thank you, Andres.
Okay.
I think what Nico's talk really demonstrates is that it's important to work in a 3D or 4D world in the cath lab when you're doing structural intervention, and you have to be able to extrapolate what you see on a flat screen into that world. And with all the different views that he uses, then I think he's demonstrating how you can do that. And of course, we already do use a lot of CT, and I think specifically in the planning of procedures, so you can take the anatomy of the individual patient and you can work a lot of the best views to see particular lesions that you want to see. But you're absolutely right. I think the future is going to be about integration. We already have echo in the cath lab. We can have CT in the cath lab. And at the moment, to some extent, we are the fusion. We do it ourselves. But there is technology now that allows us to bring these different imaging modalities together. And I think that's certainly going to be the future for some of the more complex interventions, where we're going to see fusion, augmented reality, virtual reality, and artificial intelligence all being brought to integrate all these different images into one place to allow us to do complex interventions. And I think that's going to be a very exciting time.
Excellent. So that means we bring that back on the program for next year.
I think it is very much going to be the future.
Anthony, do we have any questions from our audience?
Yeah, I think there are quite a few technical questions in and around the non-invasive imaging side of things, but probably one of the best ways of summarizing it is a question to Tom. So for the humble interventional cardiologists, we seem to be spoilt for choice with all sorts of non-invasive tests for ischemia. Which one should we choose?
Thank you, Anthony. I think not everybody is so spoiled as we are at Barts, so I think we'll take it back. So if you're in your general hospital, you just need to understand what is the local expertise and what's the availability for ischemia testing. And then depending on your setup, maybe predominantly echo, nuclear, or CMR driven, you also need to understand what's the patient characteristics and waiting time. So, At Barts, we are spoiled for choice with an exon echo service. We've heard about our nuclear capability with Rubidium PET, and we have got a world-leading CMR service where we actually can do quantitative perfusion measurement as well. So there you want to know, what about your patient and how long are the waiting times? If it's a straightforward case from your chest pain clinic, then just look at your waiting times. If you want to know the scar burden and perhaps worry that the patient may also have cardiomyopathy, HOCM, go for MRI. If they have a device and claustrophobic, go for nuclear echo. So I think those are the way forward. And I think one thing to say, when we go back at some of the head-to-head studies, MRI caught up with myocardial perfusion scanning. Now we've got PET with flow measurement, but it's only available in 4 sites in the whole of the UK, for example. We then have got CMR technologies which can do flow measurements and may be interesting also for inoco assessment in due course. So just speak to your imagers in your local center and find out what's possible.
Just know your service and get the good one, I think has always been the mantra. Time for 2 quick questions. Dan, one question came up. With your proposal to do CTCA on every bypass patient and then do an angiogram, are we not afraid of a double dose of radiation, maybe less, but contrast? Quick answer.
Yeah, no, I think that's the key question. I mean, from the trial perspective, the only interim analysis we've got from a safety perspective is the rate of AKI. But if we look at our observational data, when you took the patients that had CT and a Cath, there was less contrast than the patients that just had a Cath without CT. And therefore, I would actually suggest that a prior CT scan gives you the information that means that you use less contrast and you'll have lower rates of acute kidney injury. So I don't think that's a fear that will be sort of governed out in the trial when we present the result.
Okay, so we'll wait for those results. Great answer. A final quick question for Anthony, maybe not so quick, but it's back to the CT-FFR and the case we've seen. We've seen a case where the CT-FFR didn't match the invasive FFR. We seem to be disappointed, but probably shouldn't be. We've seen the prognosis that CT-FFR as a pathway would be cost efficient, but then the recent study in the UK didn't show that. Are we doing something wrong? Is our pathway wrong? I know you've always had a view on that.
Yeah, I think it's just a case of managing expectations. It's new technology. It costs a lot more than it hopefully will end up costing. And of course, you're sort of preaching to the wrong audience. You're talking to interventional cardiologists who like the cath labs and want to put pressure wires down, and we've got a gold standard. So in essence, you almost need to do studies that don't involve the so-called gold standard, that look at the outcome to understand whether CT-FFR can bias that. But until you do, we'll still have these debates in cases like Alex has shown, in which there's a discrepancy. And if you recall, originally the CT-FFR story by NICE was actually commissioned to validate normal coronaries. It wasn't there to basically plan revasc or anything like that in obstructive coronary disease. And maybe that cost analysis, because obviously that feeds into NICE, would have demonstrated a benefit for CT-FFR for now, and obviously in the future it will get cheaper.
Strength of CT is ruling out. We've heard that from Patrick. Okay, on that note, I will close this session. And before we go to the third session, we will have a 1-minute clip of one of our sponsors. So stay tuned, 1-minute break. Goodbye.
Great. Welcome back to our penultimate session. And we go from having been semi-invasive to start with to non-invasive in session 2 to deeply invasive. So we're going hardcore for this session. And basically, after all the talks that we've heard, really trying to address the question as to, what is the role for intravascular imaging in the current era when we've got so many choices available to us. So we'll start the session with a case presentation, and Retesh Bajaj, one of our research fellows, is going to give you a brief 5 minutes about some technology inside the coronary artery. Too much information. Retesh, over to you.
Thank you to the organisers for inviting me. My name is Retesh Bajaj. I'm one of the Interventional Cardiology registrars at Barts, and I will be doing a little case presentation on intravascular imaging under the title of Inside the Coronary Artery, Query Too Much Information. I have no conflicts of interest to declare. So let's start with a brief history. This lady that we're going to discuss is 75 years old, was referred to Barts Hospital with a history of exertional angina. She had a past medical history of hypertension, dyslipidemia, type 2 diabetes, and osteoarthritis. She had in the past a diagnostic coronary angiogram, 2011, for the same symptoms, at which stage she was informed that she had a mild left anterior descending artery stenosis, which was treated medically. Her echocardiogram demonstrates mild to moderate aortic stenosis. She has anterior hypokinesia and a moderately impaired left ventricular function. It was noted that this echocardiogram previously in 2011 was normal, and therefore for further assessment she was referred to Barts Heart Center for an angiogram with a view to proceeding as we see fit. This is the right system, which demonstrates some modest disease in the mid-vessel, in the dominant vessel. The circumflex artery similarly had a modest stenosis, as we can see there. And then when we move on to the LAD, we can see a region of moderate to severe disease in the mid-vessel, the long segment, probably with some calcification. Well, the decision was made to treat this with percutaneous coronary intervention. The vessel was wired with a cylinder wire, and this is the first balloon dilatation. The balloon was seen to go up reasonably well. It was, however, noted that at the second balloon dilatation in the mid-vessel, there was a region right there, which I'm not sure if it comes across very well on this small screen. There was a region of wasting where it was felt the balloon wasn't going up entirely, probably caused by that calcification. The operator decided then to take a cutting balloon. This was felt to expand well, and following this, some stents were deployed. And that's the first stent going up. Following on from this, between the second and the third stents being deployed, as we can see on the stent boost enhanced stent visualization, there was this region of calcification. And actually, it was felt that the stents were fairly well expanded. You can see a little bit of wasting just in the calcium right after the stent is deployed right there. And actually, the issue arose when the operator went to post-dilate. So this is the view after the stents have been put in. This is after 3 stents in the LAD. And then at post-dilatation, 7 different non-compliant balloons all burst every time at the mid-vessel, just where that calcific region was right there. The stent was post-dilated. And because this kept happening after 7 balloons, the decision was made to take an OCT to have a better look at this vessel. This is the run, and I apologize, it's playing quite fast, so I will slow it down and just go through it. This OCT demonstrates the stents are quite well opposed there. And then there's quite a lot of calcium in the vessel there behind the stent. If I pause there, there's calcification starting there in a big arc. And more calcification there. And the issue arises right there. there's a calcific nodule behind the stent there, which is actually causing a region of malapposition and pushing the stent into the vessel. And this point right here, where the stent struts are being pushed away from the vessel, is the bit that we feel was causing the balloons to burst every time. And actually, when measured, we found that the stent expansion at that area, using the Illumin criteria, comparing to the proximal reference, was 68%. To put that into context, acceptable stent expansion needs to be around 90 to 95%, and the malapposition was the other concern. So this is the situation we had with this vessel. However, after all those attempts at post-dilatation, this was the result, which angiographically, one could argue, looks more than reasonable. You can see it maybe a tiny bit of wasting, but angiographically, this result would probably be considered reasonable. And actually, at this stage, we had a bit of a dilemma. So we have referred this patient to our MDT, and the discussion is pending as to what do we do about this. Because the final result angiographically looks quite reasonable, but we have an underexpanded stent, and there is a risk of stent failure associated with that. The banner of this talk was whether this is too much information because of intravascular imaging. So let's look at the results that we actually have. The information is that the angiographic result for this PCI was good. I would argue most interventional cardiologists looking at purely the angiogram would say the result is acceptable. The intravascular imaging result, not so much, because of the underexpansion that we've seen. We know that underexpansion is a risk of stent failure. So is it actually too much information? Intravascular imaging can help in situations, particularly when you're looking at PCI outcomes and the risk of stent failure in the future. And it can help assessing complex lesions and challenging anatomies such as the calcific nodule that we've seen, and it can help guide treatment planning and how to approach such a lesion. The only question I think that arises, one could argue, is that while it is a lot more information, is what do we do with that information? And that is an area that needs to be an ongoing focus of research. Because while we have all this information was always there, we need to put this into context. It should make us reflect, I suppose, on the actual risk of stent failure and risk of failure of our procedures, and how we can do to mitigate that risk and what we can do to try and improve some of it. And I would just like to leave us with that thought. Thank you so much.
Thanks, Retesh. That really is a perfect case to start this session. I mean, there are some lovely images of a calcified nodule with clear stent under expansion and gross malapposition seen on that OCT. However, I really think the key learning here relates to the timing of OCT usage and showcases a common approach to intracoronary imaging, which is simply to assess the stent result. Here, the importance of intracoronary imaging is at all stages of the case, especially pre-stent implantation, and that's clearly highlighted if there's concerns over calcification or possible balloon under expansion. Arguably, pre-procedural OCT here may well have led to a different stent result and outcome. I think that's the key learning, and this perfectly sets up the session that's about to follow. And I'll hand back to Anthony to introduce the first speaker.
Thank you very much, Dan, for that very nice summary. I think it begs the question that based on all the discussions that we've had, what is the role for intravascular imaging in the diagnosis of disease? So I've got great pleasure in introducing my dear friend and colleague Cristos Bourantas, one of our senior lecturers and fellow consultant here at Barts, who's going to give us an update on intravascular imaging technology for the diagnosis of coronary artery disease. Cristos, over to you.
Good afternoon. Thank you for the opportunity to participate in this meeting and present about the developments in intravascular imaging. I have no conflict of interest. We know from that both in the IVUS and optical coherence tomography have a role in guiding percutaneous coronary intervention and is associated with better procedural outcomes and a better prognosis. We also know from studies comparing IVUS and OCT that both modalities have significant limitations. For example, OCT does not allow always assessment of the external elastic membrane, and therefore IVUS is superior to OCT for stent sizing, while OCT seems to be superior to IVUS for detecting the presence of malacquisition, edge dissection, and thrombus within the stent that are common causes of stent failure. Conversely, both modalities are equally effective in detecting, in assessing the plaque at the edge of the stent, which is another cause of stent failure. Acknowledging that over the last years there was an effort to combine IVUS and OCT imaging in a single catheter to enable more complete and detailed assessment of vessel pathology. The first catheter that was introduced in the clinical arena is the catheter of Conavi, and up to now 40 cases have been performed worldwide. There is also a catheter from Terumo that is likely to become available soon, and this also generates corrected IVUS and OCT frames. This is the output of the two catheters. In the top panels, you can see the output of the catheter from Conavi. You can appreciate that the IVUS complement OCT in this pair of cross sections, as IVUS can sit behind thrombus, while in this occasion, OCT enables more detailed assessment of the plaque, as it can see behind calcium and assess the thickness of the calcific tissue. The output of Terumo enables generation of hybrid images in which OCT is the dominant modality in the superficial plaque, while IVUS is the dominant modality in the deeply embedded tissues. Apart from the role of intravascular imaging in guiding percutaneous coronary intervention, it has been recognized that it has a role in identifying vulnerable plaques and patients that are likely to suffer a cardiovascular event. Several studies have compared intravascular images with histology and have demonstrated that both IVUS and OCT are capable in detecting features associated with plaque vulnerability, but they also have significant limitations in this setting. One of them is in the detection of the lipid tissue. To overcome this, a combined near-infrared spectroscopy IVUS catheter has been introduced. Near-infrared spectroscopy allows detection of the lipid tissue by analyzing the reflected near-infrared signal. It also allows detection of the collagen content over the lipid tissue, and we anticipate to have this a module in their system that will allow us to use to quantify collagen content in the clinical arena soon. The catheter has been tested in the Prospect 2 study, which included 902 patients, and it has been shown that the combination of plaque burden coming from IVUS and of the lipid content coming from near-infrared spectroscopy enables more accurate identifications of plaque that are likely to progress and cause events. Whether the quantification of the collagen content will enable more accurate risk stratification needs to be seen by retrospective analysis of the acquired data. Photoacoustic imaging is another modality that can be used in order to assess the presence of lipid. Photoacoustic imaging relies on the processing of the acoustic signal created from the thermal expansion of tissues after this being irradiated with light. Several prototypes have been developed, however, none of them had clinical applications yet. And this is because the catheters have a large size and also because they have a slow image acquisition rate. Nevertheless, over the last couple of years, there is combined IVUS intravascular photoacoustic catheters that seem able to overcome these limitations and are likely to be used in clinical practice soon. We know from animal studies that photoacoustic imaging is very effective in detecting and also in quantifying lipid component, and therefore we believe that this catheter may have significant role in the future to detect vulnerable plaques. The cap thickness is also another determinant of plaque vulnerability. Optical coherence tomography has a limitation in assessing the cap thickness, as it can always, it sometimes fails to accurately identify the presence of lipid. This is a typical example highlighting the above statement. You can see that in this cross-section there's a low attenuated plaque that lights up on near-infrared spectroscopy, while in this section there's a low attenuated plaque which does not lights up in near-infrared spectroscopy, indicating that this is a calcific tissue. Recently, Jim Miller, Gary Turney, and Greg Stone worked together to develop a hybrid optical coherence tomography near-infrared spectroscopy catheter, which is likely to have applications in the clinical arena soon. A proof of the concept report highlights the value of combining near-infrared spectroscopy and optical coherence tomography. In this case, there is a segment with many lipid-rich plaques. However, the plaque that rupture is this with the smaller cap thickness. Therefore, it is believed that the combination of cap thickness information and lipid content may enable more accurate identification of vulnerable plaques and patients that are likely to have an event. Inflammation is another factor that has been associated with increased vulnerability. OCT has limitations detecting the presence of macrophages, and for this reason, a near-infrared fluorescence catheter has been developed. Near-infrared fluorescence relies on the injection of activatable markers that bind molecules and have the ability to fluoresce when they radiate with near-infrared light. In this way, depending on the marker that we are using, we can identify the presence of catopsins, of macrophages, of collagen, on fibrin, and also of intraplaque hemorrhage. These are features that have been associated with the vulnerable plaques. Several catheters have been designed. Two of them combine near-infrared fluorescence with optical coherence tomography, and one near-infrared fluorescence with IVUS. The catheter that uses IVUS as a second modality has increased dimensions and therefore cannot be used in the coronary arteries. However, the catheter that combines near-infrared fluorescence with OCT can be useful in the clinical arena to assess the coronary arteries, and there is a proof of concept study that was published recently from the group of Harvard. Time-resolved fluorescence spectroscopy is another approach for detecting the presence of macrophages. It relies on the assessment of the fluorescence emission decay time after molecules are being excited with pulse light. Different molecules have different decay times, and therefore, with the time-resolved fluorescence spectroscopy, you can identify the presence of elastin, of collagen, and of lipid. This catheter has been combined with intravascular ultrasound, and recently the post-mortem study performed by the group of Laura Marcoux has demonstrated that this combined approach allows detection of different phenotypes, which, however, limited efficacy as there is some overlapping in the time decay times between different tissues. However, it's very helpful in detecting the presence of macrophages and also in quantifying their burden in the superficial plaque. A limitation of time-resolved fluorescence spectroscopy is that the penetration depth of this signal is only 240 microns, and therefore it can provide only information about the superficial plaque. Summarizing the evidence from the existing, from the literature, it is apparent that we have today several hybrid intravascular imaging catheters that seem to allow more detailed assessment of atheroma characteristics. These catheters are expected to enable better treatment planning and assessment of the final results post-PCI, better identification of the causes of stent failure, more accurate vulnerable plaque detection, and evaluation of the effect of emerging pharmacotherapies on plaque morphology and burden. Whether these modalities will dominate over standalone imaging needs to be seen. There is significant evolution in standalone imaging as well. A typical example is the introduction of software that enable co-registration of optical coherence tomography data with angiography, and there are software from Terumo and also from Abbott, and three-dimensional reconstruction of the vessel and the stent architecture. In addition, Abbott is expected to introduce a new software that will enable detection of the external elastic membrane and also quantification of the plaque burden, of the calcific burden and its distribution. Moreover, there are developments in the processing of the optical coherence tomography signal, and it's likely to have the clinical arena in the future polarized OCT imaging, which seems to able to detect better plaque composition and also quantifying elastin and collagen content over fibrous cap, enabling more accurate assessment of their integrity and vulnerability. Finally, we have micro-OCT that has been introduced by Gary Turney, and this approach increases the resolution of optical coherence tomography to 1 micron. In the images that can be generated with micro-OCT, we can identify not only the presence of leukocytes in the superficie, in contact with the plaque, but we can also see the pseudopods. Moreover, we can see monocytes infiltrating the superficial plaque, identify the presence of fibrin, detect the presence of thrombus, assess the distribution of cholesterol crystals, but also see cholesterol crystals penetrating a thin fibrous cuff, and this has been recognized as a cause of plaque destabilization. Summarizing, we can conclude that standalone intravascular imaging and hybrid intravascular imaging has been evolved over the recent years. Which of the two is going to dominate the clinical practice needs to be seen. However, what is clear is that intravascular imaging will be different in the next few years. Thank you very much for your attention.
Thank you very much, Cristos, for an amazing, mind-blowing talk, because the level of detail that obviously intravascular imaging is going to give us is truly amazing. Maybe overcomplicating it for routine clinical practice, but certainly I think, as we all know, we're often caught out by our lack of true understanding of this disease, how we can predict which plaque is going to rupture and how best to treat our patients. So hopefully it paves the way for the future, and I think, as we've recently discussed, the link in now with this level of phenotyping that can be done with this technology and genotyping that's out there and has already sort of leapt forward, it is going to be something that I think we'll just have to watch this space and see. So we now move on to look at the role of intravascular imaging in optimizing PCI, and I've got great pleasure in introducing again a close friend of ours, Tom Johnson from the Bristol Heart Centre, who is going to give us an update on intravascular imaging for PCI optimization. Tom, over to you.
So thanks for the kind invitation to present once again at this fantastic meeting, Advanced Cardiac Imaging course. My name's Tom Johnson from Bristol, and I've been tasked with discussing, or at least highlighting, the update on intravascular imaging for PCI optimization. I'd argue that actually we should be looking at PCI guidance, because really, having only looked once you've deployed the stent is too late. These are my conflicts. And so I think firstly, you turn your attention to the clinical reality, and the fact is we're trying to get from A, tight stenosis, to B, an excellent angiographic result. And clearly, interventional cardiologists have been highlighted as cowboys, and potentially the idea of just banging a stent in, although attractive, is not going to give the best result for our patient. And so it would be my aspiration that we turn to imaging to achieve a better result from the very beginning to the end of the procedure. And there are obviously studies at the present time ongoing testing this as a strategy, Illumian 4 in October, with specific reference to OCT. So the importance of pre-stenting OCT, well, clearly there is a need for us to understand what we're treating. And I think, as in this example, calcium is a very key issue for us to identify. And this has been beautifully represented in the Abbott Light Lab initiative, which was presented earlier this year at PCR, which was just undertaken in a dozen centers in the US with field engineers on every site, trying to adapt interventionists' approach to intervention. We actually see just in this 260 patients with calcific lesion that they do some interesting stuff in the States. So over a half of patients up front would have received a direct stent, and by virtue of using OCT, they've adapted a strategy to adopting a device. So we see that in just under half the patients that they adopted then pre-dilatation with a compliant or non-compliant balloon, or have really ramped it up with the adoption of cutting scoring in 26% and atherectomy or laser in a quarter of patients. In those where there was no change made, the vast majority were having a non-compliant balloon inflation, but there were some that were having either scoring or atherectomy utilized. And when we consider these more complex adjuncts, we actually see with the use of OCT a very significant increase in this adoption from 3% of the cohort up to 27%, driven by the image-guided approach. Now, once we've adopted this strategy, it's really important then to ensure that we have effectively modified the plaque, and then beyond that, make a choice of stent. I'll show an example where that's really important a bit later on. In terms of stent diameter, again, looking back at the Light Lab initiative data, we see that in 2/3 of cases we're pretty accurate. But worryingly, in 16% we have a tendency to oversize, where we risk injuring the vessel. And in just under a quarter of the cases, we're undersizing, where we're then at risk of leaving an underexpanded stent that could fail in the future. So let's get to the stent optimization. That was the title of the talk. And we have clearly, in the consensus document presented a couple of years ago by Lawrence, our next speaker, has highlighted we should be avoiding stenting into extensive plaque burden. We shouldn't be leaving behind malapposition. We should be avoiding dissection, particularly in the distal vessel. And there are criteria we should be attempting to achieve in terms of minimal stent area by OCT 4.5, IVUS 5.5, although I must say in my practice I've adopted a kind of 5.0 cutoff for both, or an MSA against reference of more than 80% ideally. Now, what we know from historical trials, and again, this is a nice illustration from our first consensus document, is that actually we are very, very bad at achieving the criteria in patients. So in these studies, dedicated studies, we were still failing to reach criteria in 40 or 50% of patients. The MSA that we were attempting to achieve varies from 5 to 8, so that seems slightly kind of arbitrary. And if we look at the most contemporary data, Ultimate, again, we see this 40-45% failure of reaching criteria, attempting an MSA of 5. And despite these difficulties, we actually have gratifying 3-year results just presented at ACC, demonstrating now out to 3 years this continuing superiority of imaging against angio for target vessel failure. We see again that with optimal versus suboptimal achievement of these criteria, really very significantly improved results in those that we achieve optimal criteria. And now we also see a significant impact on target lesion failure, and interestingly, albeit very small numbers, indefinite and probable stent thrombosis. Now, I'd like to just show you a case just to finish, to highlight the difficulties, but also I think the benefit of approaching cases with imaging. This was actually our first case to Illumium 4, an 80-something-year-old gentleman with very heavily calcific disease, maybe ambitious for the first case, and lo and behold, the lesion was uncrossable, and so rotablation was required. Now, importantly, the subsequent OCT shows very calcific disease with maintenance of a decent lumen distal, the cord-out channel of 1.5 with the rotational atherectomy burr, but very extensive calcification, and again, also evident upstream in this almost 3.0 millimeter lumen, to the point that then there are predictors in terms of the concentric nature of calcium, the depth of calcium, and the longitudinal extent of the calcium that suggest that this case may still be challenged by underexpansion of the stent. Lo and behold, the balloon doesn't expand. I have to take shockwave, and gratifyingly, we then see by OCT these classically punched out lesions by shockwave, and I can then make an assessment, albeit unable to land into non-disease segments, but take a 3.0 by 38 stent according to the luminal contour measurement. Post-dilate, and the first run following extensive post-dilatation shows that I still haven't quite achieved an MSA above 4.5 in the distal vessel, and the expansion is under 80%. It takes 2 further rounds of non-compliant expansion to get close to the criteria, and you could argue even still I've failed, having only got to 79% expansion at this point in the proximal half of the stent. But undoubtedly this approach has resulted in a better result, and certainly angiographically it looks so. So I conclude that we certainly should avoid just banging stents in. There's hopefully an increasing body of evidence supporting intravascular imaging for PCI guidance, and we should be considering it for lesion morphology, the modification of our lesion, the appropriate selection and landing of our stent, and striving for this MSA of greater than 80%. Thanks for your attention.
Great, fantastic, Tom, and a very compelling case for the use of intravascular imaging, although balanced against the talk of Patrick Serruys, where the implication is we could get a lot of this information with non-invasive tests. You do start to wonder on the role of it in the future, which is a nice way for us to introduce the debate. So depending the nature of who you are logged into this particular call, you might argue this is a bit of a futile debate, particularly after what we've last heard, because what we are going to debate is the question about whether intravascular imaging is mandatory for all PCI. And whilst I just briefly introduce the two speakers, and again, this is a pre-record, the way we're going to do it is hear what they've got to say. But before that, I'm going to ask you to vote in favour of the motion that intravascular imaging is mandatory for all PCI, and vote now. So basically, I think you'll get a prompt on the screen on how to do that. And then what we will do is hear what the pre-records have got to say, the pros and cons. So Lawrence Raber is going to talk in favour of intravascular imaging, and Adrian Banning has been given the rather challenging task of talking against, particularly sort of understanding his practice. But then we're also going to go to the panel to see if they have the ability to sway you as the audience in what our two guest speakers have had to say. And we'll try and do another poll at that moment in time as well to see if people have had their minds change. So I don't know where we're at with the first poll. Hopefully you're voting. Great, so that's going to be a rather quick session. Well, let's see if we can get around to the case that maybe there might be some disagreement by the end of it. Remember, the key words actually in the debate was mandatory and for all PCI. And I think, obviously, in an ideal world, maybe the answer is, oh, good, thank you very much, whoever did that. There is a way of doing that, but let's see. So let's lock that one on in our minds. So 83% think we should. Oh, it's falling, 71%. Keep voting as we start to go in. So the first speaker is going to be Lawrence Raber from the University of Bern, again, another dear friend of ours, and he's going to basically be pro the motion intravascular imaging is mandatory for all PCI. Keep voting. Lawrence, over to you, and we will come back to revote whilst we're doing the panel discussion. Lawrence.
Hello and good afternoon. Thank you very much for this kind invite. And it's my task now to take a proposition for intracoronary imaging that should be mandatory for all, at least, complex PCI. My name is Lawrence Raber from Bern University Hospital, and it's a true pleasure to do this presentation. These are my conflict of interests. So these are two post-PCI angiographies with seemingly good results. To the left, an LAD stent was placed, a 3028 postulated with 3.5, and here in the mid-circumflex, a 3.515 stent was placed. And as I said, the results were actually angiographically excellent. However, in the first case, short time after stent placement, the patient presented again with acute ST elevations and a thrombus in the drug-eluting stent. And thanks to the fact that actually we did imaging, it was clear that the reason was a gross malapposition in the proximal LAD despite hospitalization with a 3.5 non-compliant balloon. And without the use of imaging, you would actually first have missed the reason and probably blamed pharmacology. And clearly, with the use of imaging initially during the index PCI, such gross malapposition would never have been accepted. So first would have been detected, would never have been accepted and immediately corrected. In the second case, this patient presented again with a hemodynamically relevant restenosis, and imaging at this point in time actually showed that problem was there from the very beginning, because if you trace the stent area, you get to a stent expansion of 61%, which means that there was always a considerable stent under expansion that was just accepted initially, and typically it was not detected by angiography alone, and during the year there was just a little bit of neointimal hyperplasia buildup, which in concert with the stent under expansion led then to the symptomatic presentation and to this restenosis. And clearly, if intracoronary imaging would have been used at the index PCI, this underexpansion could have been prevented. So from quite a substantial number of studies, and this is just the largest among these, it is known that the imaging-derived minimal blood flow area, so in other words, the minimal stent area, is an important predictor of restenosis. And in this study, including more than 550 patients treated with this minimal luminal or stent area of 5.5, emerged as an important predictor for restenosis, as you can see here, underlined in red to your right side. And importantly, the post-intervention QCI-derived minimal lumen diameter did not emerge as an independent predictor of restenosis, which tells us that you can only predict the occurrence of restenosis using imaging-derived minimal lumen area, but not QCI-derived minimal lumen diameter, which of course speaks for the systematic use of intracoronary imaging. From 3 large European OCD registries conducted in patients presenting with early, late, or very late stent thrombosis, we exactly know which findings were present, and here is the list. This is about mainly the presence of uncovered stent struts, malapose stents, underexpanded stents, and edge dissections. And clearly, most of them, of these findings, can actually be avoided or corrected immediately at the index PCI if you detect them by intracoronary imaging. Can we really correct these adverse findings? Yes, we can. This is a large meta-analysis that has proven that if you use IVUS-guided PCI, you do improve the minimal lumen diameter for about 0.34 millimeter, and you improve your average mean stent diameter. And these are, as mentioned before, the most important predictors for restenosis. Similarly, in the RCT iLumian 3, stent expansion was improved considerably by the use of either OCT or IVUS-guided PCI, as shown in with the blue or green bar as compared to the red bar that indicates angioguidance. And as well, major malposition, a key finding in stent thrombosis patient, could be reduced, as you can see by the blue and green bar as compared to the red bar. And importantly, in another trial, a randomized trial, stent strut coverage could be considerably improved by the use of OCT-guided PCI at an evaluation time point of 6 months. So all this information cumulated in a consensus recommendation as to how a perfect PCI result should look, and you can read through the recommendations here on your own. I will not repeat them all, but the key essential points are really stent expansion, avoidance of large malposition dissection, and Blackburn at the stent edge. This slide summarizes the current class recommendation by the current guidelines, and you see that IVUS and OCD guided PCI has a 2A recommendation in selected patients to optimize stent implantation, and left main PCI guidance, it has again a class 2A recommendation. If we look at the RCTs that were conducted to compare imaging guided versus angio guided, we do see that these were mostly complex patients. There is one large all-comers trials, but here the mean lesion length was 35, so clearly low lesion category. And the other large trials also included no lesion patients, CTO patients, and complex lesions. And in the observational environment, unprotected left main PCI was frequently found, and bifurcation and acute myocardial infarction patients were frequently investigated. So I think if we look only at the RCTs and do a meta-analysis, these are the results, and you know exactly know for which patients these data holds true, for mainly complex patients. And in these patients, when we use IVUS guided PCI, we do reduce MACE for 40%, cardiovascular death for 49%. There's a strong trend towards an MI reduction of about 40% and the TLR reduction of 42%. So I think this is the key message. If we use IVUS guided PCI, you do clearly and consistently, as you can appreciate by the point estimate that is always to the left, you do improve your PCI result during the mid and long term. And this is just the most recent study performed on IVUS versus angio guidance. 1,500 patients included, mean lesion length 35 millimeter, and you do appreciate that the red curve ends at 2.9% target vessel failure at 1 year, whereas the blue curve indicating angio guidance at 5.4, which is consistent with, again, the 50% relative risk reduction. Importantly, in view of the mechanistic effect, is the comparison of a situation where you achieve the optimal result defined by an MLA more than 5, a Blackburn less than 50 at the stent edge, and no stent edge dissection. And if you fulfill all these criteria, confirmed by imaging, of course, your target vessel failure is exceedingly low, 1.6%, whereas if you do not achieve these results, it is as high as 4.4%, confirming really that if you achieve a good result, your risk for events during the next year is exceedingly low. This is not an RCT that investigated the effect of imaging, but rather an RCT that looked at the effect, the safety and efficacy of a 1-month TAP in 3,000 patients, and a 1-month TAP emerged as a better treatment strategy than 12-month TAP with respect to a NACE endpoint considering bleeding and ischemic outcomes. But it's very important to note that 98% of patients actually received imaging-guided PCI, and only with that, obviously, such good results in the short TAPT arm could be achieved. Similarly, I think it's very important to note that both in the EXCEL and in the NOBLE trial, over 2/3 of patients were treated by the use of imaging-guided PCI. So actually, the results of these two trials for the PCI arm are only valid for patients that received imaging-guided PCI. Calcium is really a key enemy as it relates to a proper expansion of the stents, and calcium is increasingly seen in our complex patients on a daily routine, and imaging helps considerably to define whether an additional aggressive lesion preparation is needed. There are very well-established scores that help to predict whether your stent will be resulting in a sufficient expansion or not. And when you use more aggressive lesion preparatory instruments like rod ablation, you actually can, by imaging, assess the effect that it immediately had, and then whether after the post dilatation, whether you really crack the calcium. And I think this is not only the detection of calcium, but also the confirmation that your preparatory strategy was successful. These are two very important indications for the use of intracoronary imaging for the treatment of complex PCI, a very practical aspect next to all the data that I presented before. At the end, intracoronary imaging is also cost effective, as shown in this large trial. You save about $3,500 per with the use of intracoronary imaging by prevention, of course, of rehospitalization due to recurrent events. So I like to summarize that over 50% of patients undergoing PCI are complex nowadays, and the clinical outcomes really require improvement. In this subset of patients, RCTs and observational data consistently show a 40 to 50% reduction in cardiovascular events, reduction in TLR in all RCTs using DES, and meta-analysis that consistently suggest a reduction in cardiac death as well. The mechanism of action is well established, as we have seen, and the main limitation nowadays to overcome the despite that huge body of evidence that is really pointing to the benefit of intracoronary imaging, the main limitation remains a modest uptake due to the extra time that is, of course, needed, the knowledge and the costs, and therefore an efficient software so that measurements are readily available and immediately available, ease of use probes, education, reimbursement, and a little bit of extra time really is required to successfully implement more routinely imaging in our daily practice. And finally, I think we do have two large RCTs that are to come, the ILUMEN 4 and October, and this will further improve the evidence on this topic. And with that, I thank you for your attention and wish you a nice Congress.
Fantastic. Thank you very much, Lawrence, for making that very compelling case. I do wonder, it's obviously a lot of technology, a lot of cost. And for every lesion, do we really need to do that? Because you sort of demonstrated that there's more than meets the eye, but can we ever trust our eye alone anymore? I don't know. So opposing the view is Adrian Banning in his little introduction from us. Obviously, Professor of Cardiology in Oxford, BSIS president just passed, and big enough to basically take the opposing view on what could be a very challenging debate. Adrian, over to you.
Hello, my name is Adrian Banning and I'm a consultant cardiologist in Oxford. And my job today is to oppose the motion that intravascular imaging is for all. I have a conflict of interest, and that is that I'm an interventional cardiologist that believes in imaging, so bear with me. But I'm also a boy, and of course boys want to win. So the first thing that I thought of when I was asked to do this was, how do I win? And I thought of three things. I could dissect the wording of the proposal, the fact that it says imaging for all. Well, clearly nothing's for everything, so I'll probably win on that point. I could slander and degrade the credibility of the other speaker, and that's what we usually do in debates in the UK. Or I could carefully consider the science and evidence and come to a reasoned argument. Ultimately, I thought I'd probably do all of the above. No, I didn't really. What I thought we would do is just to work through why people tell me they shouldn't image during PCI. They say it's not cost effective, and where's the evidence that it is? They say it takes too long and it increases the procedure time. Actually, some are brave enough to say they don't understand the images, and some say it's dangerous under certain circumstances. But of course, the real truth is that many people think they don't need to. They think they've been doing it a long time, and they actually know what's going on without taking any extra pictures. So let's look at each of those bullet points and see whether there's any background to support it. Where's the evidence that imaging during PCI is cost effective? Well, if something is going to be cost effective, it should really, reduce stent thrombosis. It should make things safer. And there isn't that much data, to be honest, to suggest that imaging reduces stent thrombosis. What there is data to suggest that outcomes are slightly better when you image. But one of the major flaws with that data is it's almost all registry data. And actually, the truth is, in all of these registries, particularly the left main, the sickest patients don't get imaged. The sickest patients do worse, and therefore those patients who didn't get imaged, who are less sick to begin with, tend to come out tops. And so imaging appears to do better. So that's a problem. If imaging is going to be cost effective, it needs to save me something. It needs to save me a stent, or it needs to save me a balloon. It needs to save me something during the procedure. And one of the major problems is we still have too many people who can't be bothered to pre-image. How can they plan their procedure when they don't bother taking any pictures before they start? And of course that adds on then to the fact that the data that suggests that pre-imaging improves long-term outcome is as yet unproven. We look forward to October, and we look forward to the Illuminium 4 study, but they're not here yet. So the cost effectiveness argument, I'm afraid, just isn't there. People say it's dangerous under certain circumstances, and of course it can be. If you've got a severe tight left main, the IVUS can be occlusive and it can cause ischemia. I saw far too many OCTs done in the presence of coronary dissection during the bioabsorbable scaffold era, where we saw huge dissections caused by people trying to do OCT. And of course we have to remember that contrast can be problematic in some patients and cause renal failure. And even the passage of the imaging catheter can cause a problem. I'm going to talk about stent deformation later. But flushing your IVUS catheter, if it's not been well prepared, can cause an air embolus. And it takes too long, and it increases the procedure time. Well, of course it does. But one of the ways we can get around that is not to spend enough time looking at the images. Well, what do I mean by that? Well, what I mean by that is I don't really understand the images. What, interventional cardiologists that don't understand the images? That doesn't really happen, does it? Well, yes, it does. You all know about the Excel trial. The Excel trial was the exemplar of the best interventional practice in the world. Or was it? In the Excel trial, we had nearly 2,000 patients randomized to either stents or surgery in expert centers, and 950 patients underwent stenting with Jain stents. And we see that we got excellent follow-up. What we saw was that in the Excel trial where imaging was done, 6.5% had acute stent deformation on the intravascular ultrasound. And that occurred in the left main ostium in 80% of the cases. Well, what was the outcome of that? Clinically, actually it was pretty bad. You can see here that stent deformation occurred with adverse outcomes in 1/3 of the cases over the 3-year period. Where there's no stent deformation, half the adverse event rate. So in this study, we see that expert interventional cardiologists bashed the stent with an IVUS catheter, caused longitudinal deformation, took the pictures, but then couldn't be bothered to look at them and do anything about it. And as I said, in this randomized trial involving the best centers in the world, people actually didn't look at the images and didn't act on them. In addition to that, there's more data on small MLA post-intervention in XL measured with intravascular ultrasound. So it's all terribly puzzling. I went onto the web to get a picture of a puzzled man, and that's the cartoon that I got. As I was doing it, I got particularly puzzled because actually about 95% of the pictures on the web of people being puzzled are of bald men. Perhaps bald men, like me, get more puzzled than non-bald men. This image came up of a puzzled man, and the more I looked at it, the more it reminded me of a CTO expert at Barts. Does he look puzzled to you? So why shouldn't I image during PCI? Well, of course, because we're doing all right without imaging, aren't we? Our outcomes are great, aren't they? Most of the time, we abolish ischemia, and the post-stent FFR is 1, isn't it? Well, no, it's not. This is a small trial that we did in Oxford a few years ago, and the data from this trial have been reproduced more recently in a number of larger studies where we did complex PCI and did FFR OCT assessment and showed that in a sizable minority, the final FFR was less than 0.8. And when we imaged, we could actually only optimize that FFR in about 1/3 of cases. Fortunately, in 1/3, we could optimize it either with further stents or further post-dilatation. But actually, we're not as good as we think we are putting in stents. And the causes of that suboptimal FFR are summarized in this cartoon here. So in this complex case series, as I've said, 1/3 of cases needed more treatment. So we're certainly not as good as we think we are. And at this point, I was going to show a small video of Lord Flash from Blackadder to represent what interventional cardiologists used to think they were like, the great man who could do anything. But of course, I think we've grown up from that, and hopefully we're now a little bit more perceptive and a little bit more aware of the real world. But the Syntax trial did represent much of that adverse practice. You know, in the Syntax trial, which we base a lot of our practice on, 900 patients underwent stenting with Taxus stents. 900 patients were compared who had CABG. This was some years ago in the heat of the ludicrous mindset of drug-eluting stents. And what we did was to put a huge number of stents in, all without imaging, all thinking we were doing a great job, up to 14 stents at one time. And surprise, surprise, as you all know, the outcomes weren't as good as we think they were. But can we just put one stent in properly? Well, this trial came from in 2008. It was a trial of the Cypher stent. And what they did was to ask American colleagues to send in their angiograms of their best stent case. And then they did some analysis on it. And they looked to see whether they put the stent in the right place, or, perhaps not so surprisingly, whether they put it in at the right size, using angiographic guidance. And what they found was that our colleagues weren't really able to do either. They missed a lot, and they put a stent in that was too small too often. So that ultimately, when we put our stents in inaccurately, we don't do a terribly good job. In order to do our job properly, we have to put the stent in the lesion, and we have to blow it up properly. No great science there. Importantly, what is the impact when we don't do our job properly? And these data from Excel, I think, are important. It doesn't actually matter whether you have bypass surgery or angioplasty. If you end up having repeat revasc within 3 years, as is shown in this graph here, you have an increase in all-cause mortality at 3 years. So any repeat revasc is really bad for you, independent of the revascularization strategy. And I think that's a really important message for all of us going forward. So what I've tried not to do is to repeat data which you've already seen, but as far as the debate goes, we can't image every case. So obviously I win, and that's important to me. How do we increase image penetration, which is what I really think? Do I think that reducing the cost of the catheters or improving reimbursement is the answer? I'm not really sure it is. I think probably we should start to use imaging as a quality metric. And I think in particular, for example, when we see stent failure, it'd be quite easy for us to see whether imaging has occurred and to look at seeing what centers are imaging and aren't imaging, to see whether we can improve that as a performance metric. I think trials of efficacy are important, and we've heard about October, and we're also doing a randomized trial of intravascular ultrasound guidance in the left main, the optimal trial, and I'd encourage you to be part of that. We've got UK, Italian and Spanish sites as part of that. And of course education, and today has all been about education and the value of imaging in PCI. The two final thoughts. One, if it was your proximal LAD, and even if it was a really simple lesion, wouldn't you want someone to image it to make sure that they've done a good job? I would personally. But finally, for those who do like Lord Flash.
Well, yes, unfortunately.
Well, I had a lucky escape, no thanks to you. This is a friend of mine. Hi! Flash out, this is Captain Darling.
Captain Darling? Funny name for a guy, isn't it? Last person I called Darling was pregnant 20 seconds later. Hey, you couldn't be bothered to help old Slacky here.
Oh, well, it wasn't quite that, sir. It's just that we weighed up the pros and cons and decided it wasn't a reasonable use of our time and resources.
Well, this isn't a reasonable use of my time and resources, but I'm going to do it anyway.
What?
This. Oh!
Thank you for your attention.
Well, that's a tough one to follow, particularly the bald man thing, who might well still be on the meeting. So let me reassemble the panels. So I'll invite Andreas Baumbach, Dan Jones, Mick Oscore, Cristos Bourantas, and Ollie Guttman. And what I'd like to do is basically see if we can get the panel to sway the audience a bit more, because essentially the pre-voting, I think there are about 300 of you on the call at this moment, actually swayed a bit. As you know, when we opened, it was 100%. Well, I'm surprised to hear that 53.8% of you agreed with the motion prior to Lawrence and Adrian going forward. And therefore, I think what we shall do is start to run the poll now that you've heard both sides of the debate. And while you're voting, you might want to hesitate briefly as we hear a little bit more from some of our panelists to see if we can sway it. So we'll divide them into two. So Cristos and Ollie are going to try and defend the motion. So intravascular imaging is mandatory. And Andreas and Mick are going to try and oppose it. And hopefully be able to match Adrian in the way he managed to do that. So first question to Cristos, and that's really about something that's always perplexed me, and this is this absolute cutoff. I think Tom mentioned it, but how on earth, in the diversity of human biology, can we have an MLA that basically tells us as an absolute that on the one side of it we shouldn't put a stent in, and the other side we should? That's just rubbish. Coronary arteries are different sizes. There's no compensation for it. Where's that data from?
Yeah, this is coming from data from studies trying to identify the best cutoff for that minimize the risk of future events. But of course, as you have said correctly, Prof. Mathur, there's you cannot stick with a cutoff. The best way to assess procedural results is to use stent expansion, and we are moving more and more towards this direction. So I would use more. I would focus more on stent expansion, aiming for a stent expansion above 80% to 90%, as was suggested in the expert consensus document, rather than aiming for an MLA of 4.5 for OCT or 5.5 for IVUS. And the different cutoff also indicates that we're using the modalities different in different vessels. In big vessels, you're using IVUS, in small vessels, you're using OCT, and that's why you have the discrepancy.
And also the cost effectiveness data. I mean, come on, these prolonged procedures, the technology costs money in itself. Losing a procedure at the end of each list in a busy cath lab, maybe if you've got enough time in the day and it doesn't make a difference, but surely this can't really be cost effective in the real world.
With the data that we have, I think we are convinced that we have to use intravascular imaging in every complex patient and in every complex lesion. For example, diabetic patients, long lesions, bifurcations, there are convincing data. You have a reducing cardiovascular mortality of 40%. And if you go to the study, if somebody goes to the studies, to the statin studies, you can see that the reduction in mortality is at the level of 20%. And we also know that the mortality benefit and the improved outcomes persist at 3 and 5 years based on the experience study and also in the ultimate 3 years follow-up study. So we don't have data from UK, but I'll just give an example. A non-generic static costs approximately £300 per year. So within 2 years, you get the cost of the IVUS catheter that you're going to use in the lab, and you need only 5 minutes. And the prognostic benefit with statin is only 20%.
All right, Cristos, now my turn to pick on Ollie. I mean, this data's, rubbish. We need tens of thousands of patients to change our pharmacological management of ACS. And here we've got a tiny minority because we like playing with toys. How can you support this data?
It's interesting to see that Cristos wants to get rid of statins, I could hear. But independent of this, to be honest, I think we have got a lot of data now. It's easy for me to argue because Tom and Lawrence gave a lot of really good arguments. But I think we've got the ultimate trial. We've got lots of meta-analysis. We've got 5,000 to 10,000 patients, and I think just the Pan-London OCT group looked at 87,000 patients and OCT use. And in all of those, as Cristos has said, there was decreased cardiovascular events, TLR, and cardiac death. And I think now we've got reasonably good data to say that intravascular imaging is what you would like to do. And I think just for me to finish off, I think independent of the data, I think if you use the family and friends test, I think it's probably easiest also for our audience to vote. So I think if some of your relatives were to come in and they had a proximal LAD or left main, I'm sure you would not say to the cardiologist, something, you don't really have to use it, just put a stent. And I think you would definitely say use IVUS or OCT and then send them home. So I think this is probably the best argument for it.
Okay, well, thanks, Ollie. So I think if everyone can continue to vote if their mind is made up. If not, we'll go to the challenging task of the opposition. So Mick, surely this is just about training. Don't people just need to be trained on how to put stents and not use all the toys? We used to basically use angiography and try and oversize the stent, and we got great results. Surely that's what we need.
Yeah, well, that's certainly what some of the professors who were teaching me were suggesting at that time. And it is an apprenticeship though, and I think Adrian put it in a good manner and maybe on Ollie's friends and family basis. Do you want an interventionist who knows how to use IVUS and knows to interpret the imaging, or do you want probably the majority of interventionists who don't know how to interpret the imaging, passing an IVUS catheter and then making up the results? So this is not for everybody, I don't believe. I believe it's for particular scenarios, so complex, long lesions, left main stems, but certainly not in all cases. And the economic argument is still not bought on me.
So, Andreas, moving on that, and we're going to close the voting in a minute. Anything you'd like to add if we're going to accept the fact that we might have to use imaging, but the debate is about using it for all lesions? What's your guidance? Who are we going to use it for?
Well, I'll put a nail in the coffin, maybe. But just to say, this is the Tuesday team. We're in the cath lab every week. We know each other's practice. We're all using IVUS. We all believe it has a value, and we all trust what we see, and we change our practice. However, to use it in everybody is neither practical nor economic. And one factor that hasn't been mentioned so far is, IVUS has been around for more than 20 years. And the only evidence that has made it into the guidelines is a weak recommendation to use it for restenosis 2A and should be used for left main intervention as a 2A. So no way we can recommend it for everybody because there's simply not enough data. Maybe in the future, maybe if we get better,
but at the moment there is no evidence to suggest we should use it in everybody, and we do good things.
Okay, well, thank you very much. Dan, final words, and then we'll look to see what the final poll has showed, which should now close. So who's won the debate? If we go back to Lawrence and Adrian, who gave the best presentation?
Yeah, no pressure there with that question. I mean, the debate was great. It's a great session. I'm slightly distracted with Cristos turning the light on. Yeah. I think, generally... well, exactly. That's clearly, illuminating the debate. I think generally we can probably agree that there are patient subgroups where intravascular imaging is mandatory to complex PCI, restenosis, stent failure, left main, long length of disease, and diabetics. But I don't think currently the evidence supports mandated intravascular imaging in all patients. The studies that have been performed arguably don't include all PCI and aren't generalizable looking at the screening logs and the patient selection criteria. So I think from a debate perspective, I think we can probably say that intravascular imaging is mandated for the majority of PCI, with complex PCI making up 50% of all PCI, but not currently is there data to support for all PCI. So on that grounds, I guess Adrian wins, which will keep him happy.
Thank you very much. Well, let's see what the final poll has got to say. Are we able to have a look and see? Oh, well, here we go. So, well, that's a sign of a very nice debate, and the fact that people have changed their minds, or maybe different people voted. But either way, it's that sort of Christmas quiz time of year, and this was all part and parcel of what we were up to today. So thank you very much to the panel for that. We will now close this session with that tantalizing view. And what we will do next is run another video from one of our sponsors. So we'll do that for a minute. Please stay on, and we'll come to the final session, which includes our keynote talk. Thank you. Welcome back, everyone, for our final session, which includes our keynote. And I've got great pleasure in introducing Professor Xavier Escanard, who needs very little in the way of introduction. World-renowned key opinion leader. His base is in Madrid. He's trained partly in the UK. More than 300 publications, including guidelines. An innovator and somebody with the rare ability to not only have the entrepreneurship, but also the complex operator skills. And I'm told he also plays the saxophone. So with little more to say, I hand you over to Xavier, who's going to talk about the Cath lab of the future. Thank you.
It is a great pleasure to participate in this cardiac imaging meeting, I should say this big cardiac imaging meeting. My name is Javier Escanet, and I have the pleasure of sharing with you some views on the Cath lab of the future. These are my disclosures. As an introduction, I think that we should say that the technological developments that we have seen over the last years will modify certainly the way that we work in the catheterization laboratory. I think that particularly the emergence of artificial intelligence could be very important in this regard. And in this particular, in this presentation, I would like to review with you some of the technical developments that will shape the way that we work in the cath lab in the future, most likely. I think the first thing, and will not go much into detail into this, is that we are going to see in our cath labs much more complex patients. I think that we will see what I call high-risk clusters, largely dictated by the fact that perhaps there will be more clinical medical management of patients with lower risk, or patients that have the profile of those included in trials like Ischaemia trials. But certainly we will be bound to have very complex patients in the cath lab. And in this context, the first modification that we will probably see is an increase of safety for both patients and the personnel. One of the aspects of this increased safety will be for reducing radiation exposure. And there are emerging technologies that are very promising and that probably will modify the way that we perform imaging without X-ray emission. One of these is the fiber optic real shape technology, the FORCE technology. It's a technology that incorporates inside the structure of the guiding catheters fiber optic mesh that actually, in virtue of being distorted by the shape of the catheter and the position, provides a real-time image on the location of the catheter. And the images that you get with this technology are, as you can see, very appealing, because you have a 3D representation of the instrument that you are using, the guiding catheter and any other device. These are actually real images obtained in a patient with a vascular graft, an aortic endovascular graft. And you can see how these catheters get visualized in three dimensions without injection of any contrast. And you can really shape this. For the time being, this technology is available only for peripheral work, but it is quite likely that this technology will evolve to the point of being able to use it in the coronary arteries. In any case, large part of the work that we do now in complex patients have to do also with the peripheral arteries. Another modality which is very appealing for imaging without using radiation is dielectric imaging. Dielectric imaging is based on the different electric behavior of different elements of the cellular structure, the sarcoplasmic reticulum, the tubules inside the vessel, etc., that act with different mechanical properties when exposed to an electric field in terms of resistance and capacitance. Now, this technology has been already proposed for obtaining images of structures, of cardiac structures, like, for example, here you can see the left atria of this patient for electrophysiology studies. As I say, it does not require radiation, does not require fusion. It provides the possibility of obtaining images of chambers. So you can imagine that this technology can be very appealing, for example, for performing left atrial appendage closure. The X-ray systems will also be enhanced, and we will have the possibility of reducing radiation by identifying the heart silhouette and center in the gantry, automatic selection of angulations to avoid vessel overlap and foreshortening. We will have the possibility of having automatic collimation with eye tracking, augmented reality and holographic result controls and fusion imaging. So a lot of the things that we are doing nowadays in the cath lab to control our hardware will be completely modified by introduction of AI features like voice recognition, natural language processing, deep learning, and holographic display. So the cath lab in the immediate future will look very different to what we are doing nowadays. We will have the possibility of using holographic display of information related to the patient. The interaction with the patient will be minimal. and you will have the possibility even to move the gantry, the C-arm of your system without touching any, say, physical knobs. You will be able to have eye tracking, so the system will be being aware all the time of what are you looking at. It will be also reacting to voice instructions. There will be a decreased margin for human error, and I think that this is something that will be dramatically changed. The Cath lab is going to be more like a cockpit-like environment where you have also supervision of artificial intelligence. So distractions in the cardiac catheterization laboratory will be diminished at a maximum, and as I say, there will be a constant surveillance by specific algorithms that will make sure that you are not committing something that is bound to generate a problem. Similar to what it was introduced in avionics a long time ago, and has clearly demonstrated that you can increase safety of air transportation, of flying. The same will be happening in the Cath lab in an immediate future. An example of this is a research that we performed with machine learning, performing an automatic analysis of pressure waveforms, that is by which the system is able to understand if there is noise in one of the aortic waveforms, if you have opened one of the side valves, etc., and you're losing pressure. And with this system, it was possible to demonstrate that the agreement that you had in the Cath lab by this artificial intelligence analysis of waveform was actually excellent as well. It was actually 100% and able to detect, for example, damping of the aortic pressure waveform by deep engagement of the guiding catheter. But recognition will be applied not only, automatic recognition will be applied not only to pressure waveforms, but also to events taking place in the Cath lab. So cameras fitted on the ceiling of the Cath lab will be able to spot events that are taking place in the Cath lab, like the patient arriving, put on the table, the physician arriving, the procedure starting by merging data coming also from the angiographic system. All these will improve enormously the workflow in the Cath lab and the reporting of everything, automatic reporting of everything that happens in the Cath lab. And of course, it will result in improved safety from many different levels. The coronary angiogram will be no longer something that will require an interpretation by the operator, by the cardiologist. We already had some good examples of intelligent recognition of the coronary angiogram, like dynamic coronary road mapping. But in the immediate future, we are going to have something that is much more closer to what we do nowadays with computed tomographic angiography, by which you will have automatic segmentation of the coronary arteries in the angiogram, and you will be able, not only that, but being able to detect automatically the presence of stenosis, calcification, thrombus, or dissection. And these are systems that actually are based on machine learning and that have a very high diagnostic yield for the time being. So this is already something real. It just needs implementation in the Cath lab. But it is not only the information that is generated in the Cath lab what will be integrated in these diagnostic processes and in decision making. The Cath lab will work as a hub for information processing, and this information will be coming from other imaging techniques obtained, other imaging information obtained in the hospital or in a remote hospital, also from epidemiological data, analytical data from patients, and all these will be integrated to perform different tasks, like, for example, assessing functional stenosis relevance, making an estimation of the prognostic impact of planned intervention. I think that prediction of results will be more and more important before embarking into the actual procedure and optimal treatment, choosing the optimal treatment modality. This is an example of this. This is a machine learning system to predict functional stenosis relevance from the coronary angiogram that is based not only on the analysis of the angiogram itself, but also from demographic data and epidemiological data that is merged with these systems. So, for example, you can see that some of the elements used by the system to estimate if a stenosis is severe or not include also data like body surface area, gender, and in the future, I'm sure it will be also the presence of or concomitant diseases like diabetes, etc. Decision-making will be supported by artificial intelligence. As a good example of this happening is, for example, some of the very sophisticated systems we have nowadays to perform longitudinal vessel interrogation, with, in this case with IFR, by which you can really map the whole vessel to understand which segment accounts for hemodynamic impairment, thus making sure that treatment is addressing the relevant coronary segment. But remember that the current situation we have is that typically for a given value of IFR, we have many of these pullback IFR shapes. And in deciding which is the segment that requires treatment, there is a lot of potential interpretation. Now, this is the results of the cerebral study that basically looked to machine learning in a system to compare the results with the gradient of operators. So you can see in yellow the segment that will be treated by a particular operator. Many operators did not include a yellow bar because they thought that this diffuse shape of the pressure pullback indicated that it was diffuse disease. But what is interesting is that the computer actually identified a very small spot in the vessel that should be treated. How is that possible? Why there was such disagreement? It was because actually the computer identified that there was a pressure drift that had escaped the analysis of the different graders, and that actually if you correct for that particular type of pressure drift, IFR drift, then you understand that there is a more limited, a smaller segment that could be treated, leading to major solution of the hemodynamic impairment. And this actually happened in 27% of cases that were judged non-significant for PCI by graders. These are the results of that particular study that were published in JACC Cardiovascular Intervention. Pattern recognition is one of the strengths of artificial intelligence. When we have a look to this, is the very nice example of chihuahuas and muffins. If you have a quick view to this picture, probably you are not able to say how many of them are chihuahuas or muffins, but of course, for an artificial intelligence system, it will be a piece of a cake compared with our ability to make sure to understand which is which. And actually, the same applies to intracoronary imaging techniques, like, for example, IRUS. So deep IRUS is one of these pieces of research that has been focused on the use of artificial intelligence applied to intracoronary imaging to improve the resolution of IRUS, and actually demonstrated that you can really move forward in the use of these techniques. We have nowadays semi-automatic systems like IRUS or IFR co-registration with angiography. We will move to a situation where IRUS provides OCT-like measurements, automatic measurements of the luminal dimensions, of plaque dimension, etc. But in the next future, by including also epidemiological data, we will be able to have predictive information as to what will be the chances of having restenosis or target lesion failure in particular segments according to the results that we are obtaining. There is an additional aspect of the changes in the Cath lab that is already the present, but is bound to expand a lot in the future, that is improving procedural precision with robotics. By the time being, we already have systems that are able to provide extreme accuracy in the handling of wires, balloons, stents inside the coronary artery. As you can see, this is again a way of reducing radiation exposure. You can see here a live case transmission in which Dr. Jean Fayadet is performing a bifurcation PCI from an external cockpit. He can perform contrast injections, like you can see here. He can handle wires. You have all type of gadgets to facilitate your PCI with this particular system. And you can anticipate that these tools will improve a lot, will facilitate much more accurate vascular access, will allow, combined with some of the holographic display that we discussed before, etc., to have an exquisite control on complex interventions. Importantly, this technology is also linked to the possibility of performing tele-interventions or teleproctoring. And I think that this is something that we are going to see more and more in the Cath lab. In some countries with a huge dispersion of the population over a large territory, I'm thinking, for example, in Australia, it can be very interesting to have the possibility that you can support or even perform an intervention at a long distance by using robotics and tele-interventions. But certainly what I believe is that teleproctoring and teleconsultations will be an integral part of the work in the Cath lab and will certainly contribute to a shared expertise in an unprecedented way. So how will these developments influence our practice? I hope that I could share with you, that I had shared with you in this presentation, that this probably will result in better stratification of patients, better planning of interventions, will increase the safety and precision of our interventions, will help us to predict final results before embarking into the actual procedure, will give procedural assistance and warning systems, will make our Cath lab a much more safer cockpit-like environment, will decrease inter and interoperator variability, and will contribute to time saving and improve the Cath lab workflow. With this, I thank you very much for your attention, and thank you again for inviting me.
That was fascinating. Thank you very much, Javier, for this glimpse into the future of our Cath lab. Who would have thought intelligence in the Cath lab, artificial intelligence, and this will be a bright and exciting future. I will need to remember to retire before the robots take over. But along the way, I think we'll see exciting developments, and we'll cover them in this course in the future. It now falls to me to wrap up our day and close. I hope you agree with me that we covered a wide spectrum of imaging relevant for the interventional cardiologist. We covered coronary angiography, non-invasive imaging, intracoronary imaging, and physiology. We did this to provide state-of-the-art updates and, importantly, discuss the relevance of the technology for our daily practice. So I hope you go away with the feeling you learned something today, maybe a lot. And maybe we confirmed that you're doing all the right things for your patients in your Cath lab. Maybe we inspired you to try new alternative ways. Well, we'll be back in 12 months from now and can discuss what changed. Then surely it'll be a live meeting. So let me thank the faculty for going through the pain of preparing and recording their talks without the benefit of a faculty Christmas dinner in London. Thanks to the panel for the question and answers. Thanks to the co-directors for creating this program. Thanks from Millbrook for running it, Alice Reed for her organizational skills in the background. Thanks to our sponsors for enabling us to do it. And a real big thanks to you, the audience, 300 of you at least at any one stage of the 4 hours program. Thanks for participating in our 11th ACI course today. With that, I wish you a good holiday season. Merry Christmas. Stay safe, and we'll meet again next year. Goodbye.